OBGY societies of Maharashtra.
Welcome, Dr. Priya.
Madam, we are live now. Shall we start?
Yeah, sure.
I extend my warm welcome to the audience audience.
Dr. Seema, पहले ही इंट्रोड्यूस करके आपको देंगे.
अच्छा, ठीक है मैम.
Good evening, doctors. I, Shuman, on behalf of Shield Healthcare, welcome you all in today's another interesting session organized by Kanpur Obstetrics and Gynecological Society along with the Association for the Maharashtra Obstetrics and Gynecological Society. Now, it's my honor to introduce our Master of Ceremony, Dr. Seema Dwivedi, Madam. Although Madam doesn't need any kind of introduction, just it's my responsibility to introduce her. Madam is a professor from GSVM Medical College, Kanpur, and in terms of award, Madam won many awards, District Gold Medal and State Level Award, IMA President Award. She was the Organizing Secretary, Quiz and National Conference. And apart from that, Madam was the Joint Secretary, Organizing Secretary, WW 2018. So with the short introduction, I request Madam to take over the session for further proceedings. So thank you very much. Madam, you are in mute.
Thank you. I extend my warm welcome to the audacious audience on behalf of Kanpur and all Maharashtra Obs and Gynae Society. We present you with stars and stalwarts of galaxy consisting of eminent personalities to bring to you plethora of knowledge on pertinent topics of litigations in MTP and genital tuberculosis. Igniting the program with lamp lightning and Saraswati Vandana. Salutations to the light of lamp that represents Shiva, Janardana, and removes my sin. I welcome and hand over the proceedings of program to our dynamic, dedicated, and diligent Secretary of COGS, Dr. Kanchan Sharma, our candidate for study of Female Breast Committee. Ma'am का CV लगा दीजिए. Dr. Kanchan Sharma, our candidate for study of Female Breast Committee, with all of.
You are muted, ma'am.
Madam is Director and Chief Consultant, Akash IVF Center, ART Specialist and Laparoscopist Specialist. She has held many prestigious posts in COGS, an icon of women empowerment, awarded with umpteen awards, Pratigya Social Impact Award, Empowered Women Award, organizer of many national and international conferences and workshops, and today's Master of Ceremony and moderator for panel. I welcome you, ma'am, and hand over the proceedings to you.
Thank you, Dr. Seema, for your nice words. At the outset, I welcome all the dignitaries, stars, and all the fraternity of AMOX and the COGS who have logged in today. My sincere thanks and regards to you. As His divine power has granted to us all the things that pertain to life and godliness. Make every effort to supplement your faith with virtue, and virtue with the knowledge, and knowledge with self-control and steady fastness that gives rise to godliness. So academic and the spiritual growth is because of your effort. So that we have to do. For that, we all are gathered today. First of all, we start our ceremony with reminding and our taking the blessings from God, Almighty God. For that, we start the program with lamp lightning and Ma Saraswati Vandana.
या वीणावरदण्डमण्डितकरा या श्वेतपद्मासना या ब्रह्माच्युतशङ्करप्रभृतिभिः देवैः सदा वन्दिता सा मां पातु सरस्वती भगवती निःशेषजाड्यापहा शुक्लां ब्रह्मविचारसारपरमा आद्यां जगद्व्यापिनीं वीणापुस्तकधारिणीम् अभयदां जाड्यान्धकारापहाम् हस्ते स्फाटिकमालिकां विदधतीं पद्मासने संस्थितां वन्दे तां भगवतीम्।
May I have the first slide of thanks? Thank you very much. May I have the first slide of thanks, Raj? Yeah. First one. Slide of thanks. Yeah. My sincere thanks. This is brochure of the Cox with Amox, and my heartily thanks to our chief guest, ever smiling Dr. Mandakini Meg ma'am, and our source of inspiration, Dr. Meera Agnihotri ma'am, our guest of honor, very ever blessing, always he is blessing Dr. Rajendra Singh Pardesi. Many times I have talked to him. Dr. Lakshmi Shrikhande ma'am. First speaker is Dr. Ajay Mane. He will be speaking on litigation in case of odds in MTP, and chairpersons are Dr. Swati Patil, President Udgir, OBGY Gynae Society. I welcome her. Dr. Anuradha Gad, President Osmanabad. I welcome you, ma'am. Dr. Vaishali Datal, President of Latur. Dr. Kavita Gandhi, President of Chandrapur. Dr. Gurpreet Kaur, Secretary Aurangabad, OBGY Society. The second panel, which is moderated by me and my president, Dr. Usha Goenka, Genital Tuberculosis in Infertility. For this, I welcome all the panelists. Dr. Kiran Pandey, she is the past President Cox. Dr. Shri Hari Lahane, President BEAD OBGY Gynae Society. Dr. Ada Shivale, President Aurangabad Society. Dr. Anil Kayante, President Jalna Society. Dr. Rachna Jaju, welcome, Secretary Latur. Dr. Vijay Shinde, Secretary Jalna. Welcome all. Dr. Praveen Mundada, Secretary Udgir. And Dr. Priya Shinde, Secretary of Chandrapur OBGY Society. Thank you all for joining us. May the blessing of this day radiate through the smile of all of you. So, we all join hand together for a education program today. First of all, please, I welcome our chief guest of the day, Dr. Mandakini Meg ma'am and Dr. Meera Agnihotri. Dr. Mandakini Meg ma'am, she was a chairperson of ICOG FOXY 2020 to 21. She was an international vice president MWIA Central Asia. She is a vice president AMWI Central Council, national vice president FOXY in 2012 to 13. She was a past president of Indian Federation of Ultrasound in Medicine and Biology, past dean of Indian College of Medical Ultrasound, chairperson of Imaging Science Committee. She was a deputy director of Health Services, GOM in charge of Family Welfare, RCH, PCPNDT, MTP, and others. She had many prestigious posts and she is awarded for many things. She had many publications. She was awarded by D.K. Datta Best Publication Award for 2 books, and she published book on PET, prevention, examination and treatment of domestic violence and sexual assault cases. She got Dr. Ganatra Award for MOX for community services in OBG by
Kanchan.
so many feathers in your cap.
Thank you, doctor.
बोलते बोलते पूरा दिन हो जाएगा तो भी कम पड़ेगा. सबसे ज्यादा तो आप, यू आर अ वेरी प्लेजेंट पर्सनालिटी. आप के ब्लेसिंग्स हम सब के लिए बहुत ही आवश्यक है. थैंक यू फॉर ब्लेसिंग अस मैम. योर स्माइल इज very good. Please bless us. Thank you for joining.
Stop sharing, please, so that I can see everyone.
This is a bouquet for you.
Thank you very much. Can you stop sharing, please, so that I can see everyone? So, good evening, everyone. First of all, I'd like to thank Kanpur OBGYN, very ever, active Kanchan Sharma and Divedi, Dr. Divedi, President, for this very nice collaboration of, our own MOX Association of Maharashtra Medical OBGYN, and we have our very popular, very efficient Dr. Rajendra, my younger brother Rajendra Singh Pardesi, Lakshmi, my friend and sister, and my elder sister Meera Agnihotri madam. आपको बहुत साष्टांग प्रणाम. और मैं सब लोगों को वेलकम करती हूँ. थोड़ा हिंदी में भी बोलूंगी. कल ही हम लोगों ने अंतरराष्ट्रीय महिला दिन को सेलिब्रेट किया. मुंबई में बहुत बड़े पैमाने पे हमारा MOGS और AMWI का कार्यक्रम भी हुआ. और सबसे इम्पोर्टेंट बात मैडम ये है कि दिस टाइम वेरी इम्पोर्टेंट दैट वी आर ब्रेकिंग द बायस. आई थिंक एवरीबॉडी नोज अबाउट इट. तो हम लोग प्लान करते हैं कि कल हमने जो शपथ ली और कल हमने जो महिलाओं के लिए उत्थान के लिए जो कार्यक्रम करना चाहते हैं, तो ब्रेकिंग द बायस एंड द जेंडर इक्वलिटी. एंड वी डिस्कस्ड इवन टुडे, in the job, in the many places there is a gender inequality which we have to break and make a sustainable tomorrow. And the climate change which is affecting mostly the women, they are the victim because they have to arrange for the food, they have to arrange for the water, they have to arrange for their livelihood, and the women has to do, महिलाओं को ही सारा काम करना पड़ता है. इसलिए सस्टेनेबल फ्यूचर का हमने कल प्रण लिया है. सो मैं सब लोगों को अंतर्राष्ट्रीय महिला दिन के उपलक्ष्य में सबको ये देती हूँ. Today is a very important day. We decided to come together. कंचन ने मुझे फोन किया. मैंने कहा कि सबसे अगर ज्यादा अच्छा यूपी तो बहुत ही विस्तृत क्षेत्र है, पर एमॉक्स भी बहुत हमारा महाराष्ट्र पे काफी अच्छा है. आप लोग इकट्ठे आएंगे तो बहुत ज्यादा अच्छा होगा. और देखिए आज हम लोग लातूर, बीड़, उस्मानाबाद, एवरीबॉडी टुगेदर. सो वेरी प्लीज टू सी एवरीवन. और ये ऐसा साथ हमेशा ही चलता रहे. सो माय ग्रीटिंग्स टू एवरीवन हियर present, Dr. Ajay Mane and all the speakers, panelists, Kiran Pandey, my dear friend, governing council member, and everyone here. So today's topic is so important that the genital tuberculosis is a major cause of infertility. You thought of very important topic on this occasion. Also, it is a silent disease. So what happens is so many times it goes unnoticed till it causes so much of damage to the endometrium and to the patient, and then they become permanently infertile. I remember when in Akola practicing, one of the chief judge was there in the bungalow, and the woman used to come to, very nice looking. And then when I did her whatever DNC and other thing, I thought genital tuberculosis to a judge living in a very open and beautiful bungalow. Then I came to know that her servant was suffering from tuberculosis. And so these are the conditions, even in the higher strata, the women are getting this. So it is very important that our clinician again, get the knowledge and the severity of and most important is the latest regimes. We have learned through many workshops the latest regimes which are being given by the government of India, free drugs, Even the ANM are taking all the drugs directly to the patients, and so on and so forth. So I think with these words, I again welcome all of you to this forum, because AMOX is our body and also UP, Kanpur is my society. मीरा मैडम, आपने जब जब मुझे बुलाया तब तक मैं हमेशा आपके आई, और मैं कानपुर को अपना ही घर मायका समझ के चलती हूँ, तो मुझे बहुत प्रेम है तो आप लोगों का। और मैं लास्ट में सबसे इम्पोर्टेंट बात कहना चाहती हूँ कि जो कंटेस्टेंट है, डॉक्टर किरण पांडे और डॉक्टर कंचन शर्मा, डॉक्टर अजय माने, और जो भी यहाँ पर कंटेस्टेंट, प्लीज you go and do your best. Always God will bless you, seniors will bless you, and do your best as much as possible. With these words, a great thank you for inviting me to this prestigious program as a chief guest, along with Meera Madam, Lakshmi, and Dr. Rajendra Patis. Thank you very much.
Thank you, ma'am, for your blessings. A grateful heart is a magnet for miracle. I woke up this morning with devout thanks giving to that Almighty God, that today is the great day that we all are gathering together. So to succeed in our mission, you must have full-heartedly devotion to your goal. ये हमने सीखा है अपनी मीरा मैडम से, डॉक्टर मीरा अग्निहोत्री. She is a chief patron, our inspiration, our role model for today's. She is always there at each and every time with us. I thank God for her presence in Kanpur. She is Dr. Meera Agnihotri. She is a professor and head obstetrics and gynae GSM Medical College in Kanpur X. She is at present chairperson of Ethics and Research State Medical Council. She is president of WWW Foundation, and she is advisor of Women Health Cell Ministry of Health, Government of India. She has taken Shapath 1000 for National Health Program, which was launched on 24th January 21. ICOG Ratna Samman and Golden Plaque 63rd AICOG 2020 Foxy Award was given to her. Impact Award for Women Empowerment and COVID Services by Cabinet Minister in July 2021. She organized International WWCon inaugurated by President of India and Union Health Minister, and successfully led collaborative groups of 13 organizations supporting Foxy position statement to Ministry of Health, Government of India for COVID vaccination to lactating and the pregnant women. There are so many awards.
Thank you, Kanchan. Thank you very much.
Thank you so much.
Let me talk
blessings.
To my friends now.
This is a bouquet for you, ma'am.
Thank you very much. Thank you very much. My dear Kanchan, Secretary Cox, and my loving President, Dr. Usha Goenka, for making me a part of this prestigious program with a person with whom I am sharing dice, none other than my very good friend, Dr. Mandakini Megh, and guest of honor, Rajendra Pardesi and Lakshmi. It's a real honor, pleasure, and I extend my gratitude for making me share this dais with such dignitaries. किसके लिए क्या कहूँ क्या ना कहूँ, we know Mandakini has done miracles in the ICOG, and she has, I will say, she has turned the table upside down, 360-degree changes, very many things which we have never heard of, learned of, and these have, and this ICOG Ratan Award advocated by ICOG, I am really, really very grateful, being the founder member. In those days, we were called as the golden members and so on. So receiving this golden plaque and whatnot is a real pleasure for me. I will ever keep it as a treasure and pleasure for me. Mandakini has done very many things which we cannot, you see, enumerate in minutes and seconds, but we are really grateful for a visionary like her for making the things possible. And now onwards, Rajendra is with us, and I'm pretty sure that I know about him, I learn about him, and I am with him in many meetings. I know that Rajendra will not leave any stone unturned to take the baton onwards and onwards. And myself and Dr. Mandakini are always with him wherever we are needed, whenever we are needed. It will be a great pleasure for us. Lakshmi, thank you very much for being with us, ever smiling, never tiring. You talk of anything, I've never heard no. So if she will ever say no, I will be not very happy. And I'm pretty sure that I will keep on listening. Yes, and that will be a delightful thing for me. Today's speakers are really very good. Litigations in MTP, it's a never-ending thing, ever changing, keeps on changing legal aspects. And when we were teachers, we were teaching that termination of pregnancy is a criminal abortion. Then it has taken over as a legality in 72 onwards, and thereafter it kept on changing and changing. And with the recent changes in the MTP program, I'm pretty sure Dr. Ajay will be doing justice in telling us the historical aspect up to this date, and with very many things which we must know and take home, and messages will be very clear. Genital tuberculosis is one of the most important subjects, I must say, that never ever diagnosed 100%, never ever diagnosed and treated 100%, but our clinical implications, clinical suggestions, and holistic approach to the patient is very, very important, because whenever teach it to the post-graduates or DNB, we keep on telling one thing, that it is never ever free from the comorbidities. So we must also concern with it. It's a very important subject taken over by Dr. Usha Goenka and Dr. Kanchan Sharma. I'm really thankful for my younger friends present from the Kanpur Obstetrics and Gynec Society and all Maharashtra OB&GY Society. I know everybody personally, and those who was not knowing, उनकी शक्ल देखकर मुझको इतना अच्छा लग रहा है. I'm finding that I am just sitting in Maharashtra or talking in between. I will not take everybody's name, but this chairpersons, Anuradha, Vaishali, Kavita, Gurpreet, they are very fully aware with them. The panelists chosen by you, Usha and Kanchan, very learned persons, Dr. Kiran Pandey, Dr. Lahane, Dr. Anuradha, Dr. Anil, Dr. Kanchan, Dr. Rachna, Rajul, Vijay, and Priya, so many others. I know them personally. I can talk to them. And even if I have not met today, I will be meeting them. And it will be a real pleasure for me. Friends, today's program is going to be a wonderful program. The journey of Foxy is never ending and it will never end. बहुत सी अपॉर्चुनिटीज हमारे यंग जनरेशन को, जिन्होंने बहुत मेहनत करी है, उनको डिफरेंट प्लेटफॉर्म पर आना है. I extend my heartfelt good wishes and love to the contestant, Dr. Kanchan Sharma for the Breast Committee, Dr. Kiran Pandey for Medical Education Committee. Medical education is a part and parcel of her life. She has worked me as a younger junior lecturer, reader, professor and head of the department. And now as a chairperson also, I am evaluating her every day. So these two persons, Kanchan and Kiran, both cases are very important for your blessings. And I believe your blessings will always be there, because जो लोग यहाँ present हैं, उनको academic, career और honesty पर विश्वास है, तो जरूर इन लोगों को support करेंगे. I never tell you that you go out of the way. You evaluate the person, and if you find that they deserve, who have given their life for medical education, and the Kiran Kanchan, who has worked so hard for it, so they are a very genuine candidate. My love and best wishes to Ajay. You will be, you see, victorious in all your missions. This is my blessing to you. With these words, I will like to I'll just stop over here because learned speakers
Ma'am,
are there.
thank you, ma'am. Thank you for your good wishes,
ma'am.
blessings. आपका सिर
So many.
हाथ हम लोग के सिर पे रहेगा तो हम लोग जरूर बहुत अच्छे से बहुत कर पाएंगे.
हमारे पास इस समय हमारी
Thank
मैम
you
चेयर
so
आपके
much, ma'am.
मैं
मैम
इस चेयर
आज
पे
आपके
अकेली नहीं
एक
बैठी
आदेश
हूँ.
का पालन नहीं कर पाएंगे वो मुझे अभी सभी अपने एस्टीम गेस्ट और पैनलिस्ट से और इनवाइटेड
बिल्कुल,
से कहना
बिल्कुल.
है कि मुझे आई वाज नॉट कंचन समहाउ बिजी रही बहुत ज्यादा, शायद मुझे इन्फॉर्म नहीं करा था कि मैं पैनलिस्ट हूँ और मैं किसी इमरजेंसी के लिए मुझे जाना पड़ेगा. मुझे
Doesn't matter.
इन्फॉर्मेशन नहीं थी.
You are always ready, ma'am.
Doesn't matter.
नहीं
So,
रेडी नहीं बेटा, मेरे और काम भी होते हैं ना.
You are always ready, and thank you for your
Today I
blessings,
can
ma'am.
नहीं
see
सॉरी
Dr.
कंचन, मैं
Mundhya,
रेडी
I
नहीं,
can
देयर आर
see
अदर वर्क्स.
Ajay is visible to me,
कॉल कर
Suman
पाया
is
था, कोई
visible to
बात
me,
नहीं.
Anuradha I can
able
see
to
you,
attend the
Rachna I
panel.
can see.
आप अपना emergency करते
So
हैं.
once again, I extend my heartfelt love
Thank you,
and blessings to all of you and all the senior persons with whom I am sharing the dais. We need your blessings for these younger generations to promote them and come forward. इसके बाद मैं एमओसी को बहुत बहुत धन्यवाद देती हूँ. हमारी परमानेंट एमओसी सीमा जो बहुत बड़ी शिव भक्त है, इसकी प्रार्थना में भी बहुत दम है. So with these words, I extend my love and blessings once again. और अपनी फ्रेंड्स को अपने बारे में बात करने के लिए मुझे बहुत अच्छा लग रहा है. Once again, मंदाकिनी, राजेंद्र and Ajay, Lakshmi. Thank you very much for being with us. Thank you very much.
मीरा मैडम एंड एवरीबॉडी, मुझे जरा माफ कीजिए, मुझे एक सेंटेंस बोलने दीजिए. मीरा मैडम, मैं भी अगले साल आपके ब्लेसिंग चाहूंगी. मैं प्रेसिडेंट फॉक्सी के लिए खड़ी हूँ और आपके ब्लेसिंग्स के बिना कुछ भी संभव नहीं है.
Okay, darling, I know it. ये बिना
मैम
बताए मुझे
नमस्ते,
मालूम था.
मंदाकिनी मैम नमस्ते.
आप लोगों को, क्योंकि इतना सुंदर योग फिर कब आएगा.
I know, I know.
Best wishes, ma'am. हम लोग आपके साथ
हम
काम
लोग आपके
करेंगे.
साथ हमेशा हैं.
आपके साथ काम करेंगे, बिल्कुल मैम.
नेक्स्ट
Thank you, ma'am, so much. Thanks. Your blessings are boon for us. I think आपका आशीर्वाद अगर हमारे सिर पे रहेगा, हमेशा वृद्ध हस्त रहेगा, तो ईश्वर भी हमारी मदद करेगा और हम लोग जरूर सफल होंगे. Thanks for your blessings, ma'am. The willingness now. The willingness to give a lot of time and energy to something because it is important. So we all have dreamt, but in order to make dreams come into reality, it takes an awful lot of determination, dedication, self-discipline, and effort. So here, with a smile comes a man with determination. I have talked, मैंने तो इंटरेक्शन किया सर से, डॉक्टर राजेंद्र सिंह परदेसी सर से. He is a president elect AMOX, but he is a great personality. He has a magnetic personality. Sir, my full-heartedly regards to you. Dr. Rajendra Singh Pardesi, he is first vice president of AMOX. He has written 27
okay, Kanchan, it's okay. It's
Sir.
okay. Good evening, everybody. Thank you, Dr. Kanchan, for your kind words. Kanchan is very active. Kanpur society is vibrant, I think, in UP. So, respected Dr. Mandakini Meg ma'am and Dr. Meera Agniotri ma'am, Dr. Lakshmi Sikande, and all faculties, panelists, and delegates. I am feeling really proud to be a part of this webinar, which is blessed by Dr. Meera Agniotri and Dr. Mandakini Meg madam. I know it will be a feast, academic feast, under all these panelists and faculties. I congratulate Kanpur Vijay Society with the AMOX societies, Aurangabad, Bid, Jalna, Udgir, Chandrapur, Latur, and Usmanabad for organizing this such a nice webinar. I wish every success to Dr. Ajay Mane for his future elections as Vice President Foxy, and to Dr. Kanchan Sharma for her chairperson, Breast Committee, and to Dr. Kiran Pandey also for her chairperson in Medical Education Committee. Again, I wish every success to this webinar. I don't want to become in you and the scientific content. Thank you so much for inviting me.
Thank you,
Thank you,
sir,
Dr.
for your
Pardesi. Thank you.
blessings.
Thank you.
So strong, I can say, so strong. You are so gentle, so educated. You are so humble, so passionate. You are so rational and so disciplined, sir. We have to learn a lot many things from you. Now, welcome our other most smiling goddess of beauty, our next guest of honor, Dr. Lakshmi Shrikhande. There is nothing more attractive than a great positive personality, ma'am. Its beauty never fades away with time. That is you, ma'am. Your personality is a very magnetic personality, ma'am.
You
Dr.
can
Lakshmi
skip the intro slide, yeah.
Ji?
You can skip the introduction slide, yeah.
नहीं, that is very important. अच्छा, आपने skip कर दिया है. थोड़ा सा पढ़ लेते. बस थोड़ा सा पढ़ लेते.
पढ़ो हाँ पढ़ो.
She is a chairperson elect ICOG Indian College of OBGY. She is a national corresponding editor of Journal of OBGY of India, Jogi, and National Corresponding Secretary Association of Medical Women of India. She is a founder, patron, and president of ISOPAR Vidarbh Chapter 1921. She has got so many awards, so many orations and publications, and सबसे ऊपर she is a very ever smiling magnetic personality. In a short your introduction, ma'am, I need your blessings. Please welcome here. This is a bouquet for you, ma'am. Give us 2 words of blessings.
Thank you so much, dear Kanchan and President Dr. Usha, for inviting me as guest of honor for this wonderful program. And it's really a pleasure and privilege to share this with my elder sister and philosopher guide, Dr. Mandakini Meg Madam, my mentor, Meera Madam, my dear friend, Dr. Rajendra Singh Pardesi. So I'm really happy to be part of this webinar, and you have chosen 2 very important topics, Kanchan. And with the contradictions between POCSO and MTP Act, I'm sure Dr. Ajay will highlight all the points in how to keep yourself safe and be with the POCSO Act also, and with the latest that new MTP Act also. And your panel on genital tuberculosis is also a very thoughtful topic, because still I also feel that it is very complex and complicated topic. So I'm sure you all will be giving practical tips to all the practicing gynecologists for managing genital tuberculosis, because it's really common in our infertility practice. And Rajendra Singh Pardesi, thank you so much for initiating this collaboration with the societies and inviting these 5 societies under the banner of AMOX to join hands with Kanpur, because collaboration always brings great results and great participation with all the interested people. So it's a wonderful program. I extend my best wishes to Dr. Kanchan, Dr. Kiran, and I know Ajay is already a winner, but to Ajay also, best wishes for your election campaigns, and my best wishes for the grand success of this webinar as well. Thank you so much once again for inviting me here.
Thank you, Dr. Lakshmi. Thank you.
Thank you, ma'am. Your words are and your personality is really a magnetic personality. You have given us blessings, and thank you so much to bless us. Now the first speaker is our VP. आप कहते हैं आप पहले ही जीते हुए हैं, तो हम भी ये कहते हैं डॉक्टर अजय माने आप पहले ही जीते हुए हैं. Sir, and you are a very good speaker and wonderful personality. मुझे जैसे कि इंटरेक्शन जितनी बार भी किया, wonderful personality. हमेशा any time whenever I ring, he responds with a smiling face and always tries to help. This is his quality. So he is our first speaker. Now to introduce the chairpersons of the first speaker, I hand over mic to my MOC, Dr. Seema Dwivedi. Dr. Seema Dwivedi, please introduce the chairperson of the first topic.
Thank you, Kanchan ma'am. It is my proud privilege to introduce a colorful plethora of panel of chairpersons. And our first chairperson is President Udagir Obs and Gynae Society, Dr. Swati Patil. She has worked as lecturer and associate professor at Solapur Srini Medical College for 5 years and has then practiced at Udagir for 18 years. You're welcome, ma'am.
Welcome, Dr. Swati ma'am. Yeah. This is a bouquet.
Our second chairperson, a pleasant personality, Dr. Anuradha Garad, President Osmanabad Obs and Gynae Society, Director Garad Hospital. She has done her fellowship in laparoscopy and infertility and has done advanced ultrasound training. Welcome, ma'am.
Welcome, Dr. Anuradha. She's there. This is a bouquet for you. Yeah.
Our third chairperson is President Latur Obs and Gynae Society, Dr. Vaishali Dattal, practicing for last 20 years as Director, Sarthak Hospital, past Treasurer and Secretary Logs, has conducted various ligation camps and educational workshops, faculty at state and regional conferences. Welcome, ma'am.
Welcome, Dr. Vaishali. This is a bouquet for you.
Yes, thank you, madam. Thank you.
Thank you for joining. Yeah.
Yes. Our fourth chairperson, a pleasant and dynamic personality, Dr. Kavita Gandhi, President, Chandrapur Obs and Gynae Society, Consultant Obs and Gynae at Gandhi Hospital, Chandrapur, Foxy Lead Assessor to Lakshya Manata Mission, and has association with many government projects, Manyata Vikas Government Project, Prant Pradhan Jan Suraksha Yojana, and she is past Vice President, IMA Chandrapur, and ex-senior gynecologist at Government Hospital.
Welcome, Dr. Kavita ma'am. Welcome. This is bouquet for you. Yeah, welcome.
Our next chairperson, Dr. Gurpreet Kaur, Secretary, Aurangabad Obs and Gynae Society, Executive Committee Member, ISC and IAEC, practicing in Aurangabad for 15 years, consultant as CSMSS Multi-Speciality Hospital, has presented various papers and published many papers in national and international journal. You are welcome, ma'am.
Welcome, Dr. Gurpreet.
Thank you so much.
This is bouquet for you.
It's very beautiful, madam. Thank you so much.
Thank you so much. Now, may we request Dr. Swati Patil, ma'am, to introduce our speaker of the day. Speaker, Dr. Swati Patil, ma'am, please introduce our speaker, Dr. Ajay Mane. Please show the CV of Dr. Ajay Mane.
Madam, can we skip that? We'll save time. Yeah, no problem.
बस थोड़ा सा बोल देते हैं कि
कुछ नहीं, नाम पहली लाइन बोल दीजिए.
Can I?
हाँ,
Yeah,
please,
please.
Dr. Vaishali, please.
It gives me pride to introduce Dr. Ajay Mane, sir. He's a member of NIMC National Inspection and Monitoring Committee, PCP&DT. He has done many good jobs in medical legal consultant since 18 years. He is the chairperson, official AMOX. He has many feathers in his cap, ma'am. He is health advisor, sports authority. He is ex-superintendent, MGM Medical College, Aurangabad. So
Yes, ma'am. Thank you. Thank you very much, ma'am. Thank you very much for that great words.
He is a candidate for the post of VP Foxy West
Yeah,
Zone. This is a bouquet, sir, for you.
Thank you, Kanchan, ma'am.
Thank you. Welcome.
Can I share?
Sure, sure.
Yes, ma'am. Now we'll start. Routine questions. Is it seen completely? Full screen?
Right.
Yes, sir.
Yes. Thank you, madam. Thank you, chairpersons, Kanchan ma'am, Usha ma'am, then our beloved Mandakini Meg madam, then Miragini Hutri madam, Lakshmi madam, and Pardesi sir. These four all are my mentors basically. So getting Ashirwad from them is a very big thing, and together that too is very important. Thank you for the Ashirwad and all the chairpersons. So I welcome them also. Mandakini madam, Meera madam, Rajendra sir, Lakshmi madam, and Usha Goenka madam, Kanchan Sharma madam, Kiran Pandey madam. Thank you very much. Kiran Pandey madam, I think, has left. And I'm very much thankful to Kanpur Observation Society for giving me chance, and my own societies of Marathwada, Udgir, Usmanabad, Latur, Aurangabad, and Chandrapur had joined this time. Jalna, Bid Observation Society, and Dr. Swati Patil ma'am, Anuradha Garad ma'am, Vaishali Datal ma'am, Kavita Gandhi madam, Gurpreet Kaur ma'am, Srihari Lahane sir, Anuradha Shevale madam, Nilkande sir, Dr. Priya Shinde ma'am, Dr. Praveen Mundara sir, Dr. Vijay Shinde sir, and Dr. Rachna Jaju madam. Thank you very much. And the MOC, most efficient MOC, Dr. C. Madhvi madam. Thank you, Shield. Now we come to the topic. Basically, I'll be going quickly to the slides. Patient came with a pregnancy of 17 weeks. I'll tell you the situation. 17 weeks, MTP, and her age is 17 years. What next? See, here at the POXO. What is the POXO? Protection of child from sexual offenses. It is the long form. Protection of child from sexual offenses. Many of the consultants, they utter it as a POSCO. It is not POSCO, it is a POXO. Okay, first thing. Formed in 2012, then amended in 2019, and so many amendments. And the main provision is that if you find a patient who is pregnant and who is less than 18 years completed, then you must inform the police. That is the provision for all consultants. Maybe gynecologist, maybe pediatrician, maybe a sonologist, maybe a surgeon. Okay, everybody. Rather, the POXO Act says that the person who is a non-medico and who came to know that she is pregnant, she is less than 18 years, should inform the police. Maybe a gully neighbor, or maybe a colony person, or somebody. Anybody who knows must inform. And if you do not inform, say for an example, patient is coming to our hospital and we are not informing, then we are liable for 6 months imprisonment. आपने अगर पुलिस को इन्फॉर्म नहीं किया तो आपको 6 महीने की जेल हो सकती है इसमें. There is a discretion of the magistrate, first class judicial magistrate. Okay. So here क्या है? 17 साल की लड़की है, coming for MTP, and 17 weeks pregnancy. 17 weeks of pregnancy is no problem as on today. Previously also it was not problem. 20 का 24 कर दिया, that is better thing. But 17 years है तो आपको POXO के लिए आप पुलिस को इन्फॉर्म करना पड़ेगा in written format, have received from them, and you can proceed for the MTP. Follow protocols बोल दिया मैंने आपको, documentation क्या करना है, आपने पूरा consent लेना. आप consent किसका लें? Same patient whose signature is essential. As she is 17 years, she becomes a minor. Okay. In minor cases, we need to have a consent of the parent or the guardian, and not legal guardian. Legal guardian means who is having a official custody of that child is a legal guardian. Here, legal guardian is not mentioned. Previously, it was there in 2003 amendments. They have removed it. Now, only guardian is who is a guardian? Who is accompanying the patient is a guardian. Maybe a boyfriend, maybe a friend, maybe mother, father, or whosoever. Okay. So, warden, matron can be also a guardian. And अगर उसके पास कोई नहीं है, absolutely कोई नहीं है, तो head of the hospital can be a guardian. That is a provision. Okay. So, parent and guardian. If she is a more than 18 years, say for an example, she is more than 18 years. Back same situation. Patient came with a pregnancy of 17 weeks for MTP and her age is 18 years. Then whose signature? Only patient. 18 साल के ऊपर है तो हम लोगों को पेशेंट का सिग्नेचर लगेगा, not her husband, not her father, not her mother, not her sasu or anybody. Okay, only patient signature. One witness is compulsory. Doctor signature is compulsory. Why? It is an agreement between two parties. One party is doctor, one party is patient. So दोनों की sign हुए बगैर that consent is not complete and valid. Fine. Okay. Next situation. Patient came in bleeding and infection. Okay. She had attended by quack or taken MTP pill through quack. How can we proceed? Now she has tried a illegal abortion. Okay. Here age is not mentioned. So maybe we'll consider it as a major, more than 18 years. If less than 18 years, then again POXO and other things. If she is more than 18, अब यहाँ 18 है ऐसा हम पकड़ के चल रहे. Inform police as it becomes illegal abortion and sometimes goes wrong. If she succumbs, infection है, septicemia में गई, patient DIC में गई, डेथ हो गया या ब्लीडिंग बहुत ज्यादा हो गई, शॉक में गई, उसका कुछ बहुत ज्यादा प्रॉब्लम हुआ, तो उसमें क्या बोलेंगे? आपके हॉस्पिटल में हुआ है, यू आर लायबल फॉर. बट patient came with the bleeding and infection. ये जो initial notes है ना, those are very important. Notes on admission is very important. आपने उसमें पूरी कंडीशन उसकी बयान करनी है, उसका पेशेंट का पल्स, बाकी ये वो सब और पूरी इन्वेस्टिगेशन डॉक्यूमेंट्स अटैच विद इट. एंड इफ शी हैज गॉट दिस मच हिस्ट्री, इन्फॉर्म द पुलिस, मेक एन MLC मेडिको लीगल केस करके आप एक रिसीव्ड लीजिए पुलिस से. यू आर फ्री. You are not negligent or you are not liable for any punishment because you are treating the patient. It is a life-threatening condition for the patient. That's why you are treating. It is obligatory for you to treat a life-threatening condition. If the patient is not in life-threatening condition, घूमते घामते आ गई है, आपको बोली मैडम मेरा MTP करो, आप बोल सकते कि नहीं कर सकते, मुझे नहीं करनी है. We can deny. That is our right. हम पेशेंट को डिनाई कर सकते हैं, वो हमारा अधिकार है, कानूनी तौर पर दिया हुआ. कब तक? जब तक कि पेशेंट इज नॉट इन लाइफ थ्रेटनिंग कंडीशन, उसकी जान जाने की नौबत आ गई है, तो यू हैव टू ट्रीट दैट. उसमें आपका कंसेंट नहीं भी लिया तो चले. पेशेंट अगर बहुत ज्यादा सीरियस है तो कंसेंट लिए बगैर भी आप उसका ट्रीटमेंट, बहुत ज्यादा ब्लीडिंग में आया है, सेप्टिसिमिक या तो PPH के शॉक में है पेशेंट, एकदम पल्सलेस बीपलेस है आपके पास, किसकी कंसेंट लेंगे? आपको पेशेंट की जान बचानी बहुत जरूरी है. दैट टाइम लॉ ऑल्सो एग्रीज दैट योर प्राइमरी ड्यूटी इज टू सेव द लाइफ ऑफ द पेशेंट. कंसेंट जरूरी नहीं है. ओके, fine. Next situation. Police calls you and demands case paper of MTP you performed 2 years back. This is a routine situation. As girl filed case against that boy as a rape case. अब ये बहुत नया सिचुएशन आ गया है आजकल के जमाने में. 2-3 साल उनका सेक्सुअल रिलेशन रहते हैं एंड आफ्टरवर्ड्स मे बी 2-3 years आफ्टर कुछ तो भी उनका झगड़ा हो जाता है. दे सेपरेट्स and in certain or some instances that girl files FIR against that boy कि इसने 3 साल तक मुझे रेप किया. अब रेप कैन नॉट बी 3 साल तक, ये तो कोई भी छोटा बच्चे भी बोल सकता है कि नहीं. बिटवीन 2 रेप्स व्हाई शी हैज नॉट गॉन टू पुलिस, इसका कोई आंसर नहीं है. बट ऑल आवर लॉज आर फेवर टू द वुमेन साइड. ओके, सो दैट बॉय इज इन ट्रबल. अब उसमें ये हो सकता है कि किसकी गलती है, क्या गलती है, वी आर नॉट जज. वी आर नॉट देयर टू जज द पोजिशन, जज द सिचुएशन. वी आर देयर टू गिव द मेडिकल हेल्प, दैट्स ऑल. सो इसमें हमारा रिलेशन क्या आता है कि हमने उसको 2 साल पहले उसकी MTP की थी. एट दैट मोमेंट शी वाज मेजर, है ना, उसका मे बी 20-21 ईयर्स उसका. अब परसों एक पेशेंट आया था, केस आई मेरे पास एक डॉक्टर की, उसमें 21 ईयर्स वाज द पेशेंट्स एज. डॉक्टर हैज टेकन द आधार कार्ड, kept it with hospital documents, everything is fine. सब कानूनी तौर पे है. पेशेंट वाज प्रॉपर, MTP सेंटर रिकॉग्नाइज है, पेशेंट वाज मेजर, डॉक्टर वाज रिकॉग्नाइज, एवरीथिंग. बट अभी उसने केस कर दिया रेप का. क्यों? 3 साल से इसने मुझे रेप किया है. अब उसमें क्या करेंगे? एज द इंस्पेक्टर हु इज आस्किंग मस्ट गिव एन एप्लीकेशन टू यू डिमांडिंग द सिचुएशन कि नहीं ये आप ये करो, दे दो, पेपर्स के झेरॉक्स दे दो. As it is a cognizable offense, the investigating officer he can demand or she can demand basically, and उसको देना आपको obligatory है. तो have a photocopy of your documents, उसको right side में नंबर करो 1 2 3 4 5 6 7 8 and उसको hand over करो and have a received कि I received 7 papers of such and such patients. उसके साथ में एक लेटर देना है उसको कि this comes under MTP Act. The confidentiality must be maintained by all of us. So I am giving you under the obligation of law and henceforth to maintain the confidentiality is your duty. ये उसमें सेंटेंस लिखना है. पुलिस वाले भी फिर डर के रहते कि इनको कायदे कानून मालूम है, एंड देन ओनली दियो। आप एक एप्लीकेशन लीजिए और उनके बाद में उसको फोटोकॉपी दीजिए, ओरिजिनल किसी को भी देना नहीं। कुछ लोग पुलिस आते हैं ऐसे घूमते घामते, मुझे बताओ, नहीं बता सकते, आप एप्लीकेशन दो। नहीं हम एप्लीकेशन नहीं देंगे, हम इन्वेस्टिगेटिंग ऑफिसर है। उनको बोलना देखो कायदे कानून हमको है, कायदे कानून आपको भी है, हम आपको नहीं दे सकते जब तक कि आप हमको ये नहीं बताएंगे कि ये केस आपके पास है, आपका ऑफिशियल लेटर चाहिए मुझे विद पुलिस स्टेशन स्टैम्प, देन एंड देन ओनली आई विल गिव। वो घूमते घामते आ गए, दिखाओ, नहीं दिखाए, किसको दिखा सकते हैं? सिविल सर्जन को दिखा सकते हैं, या एमओएच है कारपोरेशन लेवल पे उसको दिखा सकते हैं, एमटीपी वाला बोल रहा हूं मैं, एंड उसका कोई सबऑर्डिनेट है, उसका कोई डॉक्टर है जिसको डेलीगेशन ऑफ अथॉरिटी किया हुआ लेटर उसके साथ में है, उसको यू कैन आस्क पोलाइटली कि मैडम आपका लेटर बताइए, देन एंड देन ओनली आई विल शो। अब इसमें पंतप्रधान भी आ गया तो आप दिखा नहीं सकते एमटीपी का, इट इज अच्छा कॉन्फिडेंशियलिटी ब्रीच हुई तो उसमें 1 साल का प्रावधान, आपको इम्प्रिजनमेंट फॉर 1 ईयर। जो भी करते हैं उसमें वो इंस्पेक्टर भी आता है, उसने भी अगर ब्रीच किया तो वो भी आएगा। जिसका कोई ताल्लुक नहीं है, अगर पुलिस वाला आके बोलता है मुझे डॉक्यूमेंट दिखाओ, जबरदस्ती उसने देखने की कोशिश की, उसको भी वो 1 साल का प्रावधान लागू है। डरने की बात नहीं है, कायदे सबके लिए सेम रहते, वो पुलिस में रहो या कुछ भी रहो, ठीक है। अब इसमें थोड़ा ये थोड़ा डिटेल है, इसमें नहीं जाऊंगा मैं। फॉल्स प्रॉमिस ऑफ मैरिज में एफआईआर हो सकता है, ब्रीच ऑफ प्रॉमिस ऑफ मैरिज में उसको सिर्फ कॉम्पेंसेशन देना पड़ेगा, ये अलग बात है, वो एलएलबी के लेवल की है, इसमें अपना कोई ताल्लुक नहीं उससे, ठीक है। बाद में बताता हूँ। Situation: patient came for USG for pain in abdomen. Patient is 16 years married, very nice, and found pregnant of 8 weeks. What next? ये सेम सिचुएशन मैंने आपको बताया। पेशेंट पेन इन एब्डोमेन बोल के आई, सोनोलॉजिस्ट को दिखा कि उसमें उसकी 8 वीक्स की प्रेगनेंसी है, एंड पेशेंट का एज कितना है? 16 years. At that moment, that sonologist must inform police. And moreover, the gynecologist who has sent for the sonography, he also or she also should inform the police. And NGO or Mahila Ayog coming for inspection, can we show documents? No, absolutely not. It is now happening in certain areas of Maharashtra. Some Mahila Ayog is coming and asking for the documents. Maybe she is accompanied by the local medical officer. तो local medical officer को बोलना है कि सर आप हमारे medical officer हो, you have got complete right to see the documents. आपको दिखा रहे हैं, ये इनको जो आप दिखा रहे हैं इलीगल है, ये आपकी जिम्मेदारी है। ये हम शूटिंग कर रहे हैं, अपने हॉस्पिटल में शूटिंग करना अपना अधिकार है। आपल्या हॉस्पिटलमध्ये आपण शूटिंग करू शकतो, व्हिडिओ कॅमेरा चालू करा, त्यांच्याशी बोलणं, तुमचं शूटिंग करा, ते म्हणतील तुम्ही कसं काय शूटिंग करताय, त्यांना सांगायचं हे माझं हॉस्पिटल आहे, माझ्या हॉस्पिटलमध्ये माझ्या प्रेमाइसेस मध्ये मी शूटिंग करू शकते, कायद्याने मला तो अधिकार आहे। महिला आयोग असो, एनजीओ असो, पोलीस असो, सगळे घाबरतात, कायदे सगळ्यांना सारखे असतात। तुम्हीच घाबरून बोलायला लागले की तुम्हाला जास्त घाबरव, तुम्ही अजिबात घाबरायचं, तुमचे अधिकार खूप आहे, ओके। सो डोंट बी फ्राइटन, डरने की बिल्कुल बात नहीं। कैमरा चालू करो, उसके सामने बोलो कि सर ये मैं आपको दे रही हूँ बिकॉज यू हैव गॉट अथॉरिटी। आपका भी लेटर मैं पूछ सकती हूँ, आपको सिविल सर्जन ने दिया हुआ तो वो दीजिए, वो दिखाइए। अगर वो आपके साथ अभी लेटर नहीं है तो अभी तो मैं आपको डॉक्यूमेंट बता भी नहीं सकता। महिला आयोग की कोई भी आने दो, महिला आयोग के अध्यक्ष भी क्यों ना आए, उसको नहीं दिखा सकती। कोई एनजीओ है उसको भी नहीं दिखा सकते जब तक कि उनके पास कोई अथॉरिटी लेटर हो, गवर्नमेंट ऑफ महाराष्ट्र या गवर्नमेंट ऑफ इंडिया का, नहीं बता रहा। नेक्स्ट सिचुएशन, पेशेंट साइकोलॉजिकल डिस्टर्ब, लेटर फ्रॉम साइकियाट्रिस्ट ऑफ हर ट्रीटमेंट, वो लेके उसको अटैच करो उसकी ट्रीटमेंट, क्योंकि कुछ ड्रग इंटरेक्शन हो सकते हैं, इसलिए उसका लेटर बहुत जरूरी है। एंड एज शी इज मेंटली नॉट फिट टू गिव द कंसेंट, कि उसमें फिजिकल एंड मेंटल फिटनेस चाहिए, मेंटली फिट नहीं है तो उसमें कंसेंट फ्रॉम गार्डियन और वार्डन इज नीडेड। Do we need to change our MTB registration certificate from upper authority has changed from 20 weeks to 24 weeks? Now amendment has took place. Then उसमें अगर हमारा 20 तक का है तो उसमें 24 के लिए अलग से सर्टिफिकेट वापस करके नया लेना पड़ेगा? एब्सोल्युटली नॉट। अभी दोपहर में मैंने सिविल सर्जन से बात की, उनका फोन आया था कि सर ये देना पड़ेगा ना, नया देने की जरूरत नहीं। गैजेट में लिखा हुआ कि 24 वर्ड मस्ट बी रिप्लेस्ड एट द प्लेस ऑफ 20 वीक्स। गॅजेट में क्लिअर कट लिहिलेला आहे, त्याच्यामुळे आपल्याला सर्टिफिकेट वापस करून नवीन घ्यायची गरज नाही। काही ठिकाणी मागितलंय, त्यांनी मागितलं असेल तर द्या त्यांना, त्यांच्याकडनं नवीन मिळेल विदाउट सिंगल रुपी, त्यात पैसे लागणार नाहीत तुम्हाला। फाइन, नॉट इंडियन झालं। कैन वी टर्मिनेट प्रेग्नेंसी आफ्टर 24 वीक्स एंड आफ्टर 28 वीक्स? यस, पहले 20 वीक पर होते, नाउ इट हैज बिकम 24 वीक्स, अप टू 1 to 12 one consultant, 12 to 20 2 consultant previously, but in new amendment they have made it a single consultant. So 1 to 20 is a single consultant, 21 to 24 is 2 consultant, and after 24 medical board. That's all. Medical board has to give within 3 days and the consultant has to terminate it within 5 days. So 8 दिन की बात है उसमें, ओके, इसमें ज्यादा कुछ नहीं बोलूंगा. Is failure of contraception available after 20 weeks? Failure of contraception is made available for non-married persons also. अब तक के बिफोर अमेंडमेंट क्या था, ये जो कॉन्ट्रासेप्शन फेलियर है ना, 5वां प्रावधान, ये था सिर्फ अप टू मैरिड वुमेन. अभी वो अनमैरिड को भी ओपन कर दिया है, बट इट इज अवेलेबल ओनली अप टू 20 वीक्स. 20 वीक्स के आगे आप ये लिख नहीं सकते. 20 वीक्स के आगे सर्टेन सिचुएशन है, रेप है, फिर माइनॉरिटी है, या जियोग्राफिकल है, या विडोविड है, या तो फिर उसका अनोमली स्कैन, ये 5 में से कर सकते हैं. फेलियर ऑफ कॉन्ट्रासेप्शन नहीं दे सकते. ओके, next situation, is USG mandatory before MTP? By law it is not mandatory, but by my opinion you should do, because it tells about the intrauterine, extrauterine or heterotropic pregnancy. And secondly, the gestation age. If it is on 13 or 14th week borderline and you are having only first trimester abortion certificate with you, and something goes wrong, police catch you and it proved that it was 14 weeks pregnancy, you are at problem. So the gestation age is very important उसमें, इसलिए आपको इन सोनोग्राफी करना जरूरी है. ऐसा मेरा ओपिनियन है, कायदे कानून से ओपिनियन जरूरी नहीं. इज इट मैंडेटरी इन मेंशनिंग मिस्ड अबॉर्शन, इनकम्प्लीट अबॉर्शन, इनएविटेबल अबॉर्शन एंड प्लाइटेड ओवम इन एमटीपी? नो. सी मेंटल, ये मिस्ड अबॉर्शन, इनकम्प्लीट अबॉर्शन, इनएविटेबल अबॉर्शन एंड प्लाइटेड ओवम, ये जो है दे आर ऑब्स्टेट्रिक कॉम्प्लिकेशंस. उसको एमटीपी में डालने की जरूरत नहीं है. उसको फॉर्म 1 भी भरने की जरूरत नहीं, फॉर्म सी भी भरने की जरूरत नहीं. बट इफ यू आर गोइंग फॉर द डायलिटेशन एंड क्यूरेटाज, सक्शन इवैक्यूएशन, उसके लिए अलग से कंसेंट लीजिए, एनेस्थेसिया कंसेंट लीजिए, आप पेपर इंडोर के अलग से मेंटेन कीजिए और उसको रख दीजिए. इन महाराष्ट्र दे आर आस्किंग फॉर नेचुरल एबॉर्शन केसेस. तो सो दिस 4 आर नेचुरल एबॉर्शंस. तो आपको जो देना है एमटीपी, मेरे हॉस्पिटल में भी इस महीने में 36 एमटीपी डन एंड नेचुरल एबॉर्शंस 4. तो आपको दोनों का डेटा देना है. गवर्नमेंट ऑफ महाराष्ट्र तक ही सीमित है, रेस्ट ऑफ इंडिया उन्होंने अभी ये मांगा नहीं. पर महाराष्ट्र इज वेरी फार अहेड, बिकॉज वी हैव मेड अमेंडमेंट, रादर गैजेट में भी दिया उन्होंने कि 14 की जगह 16 कॉलम का रजिस्टर एमटीपी का, एंड 13 कॉलम में 20 की जगह 24 करके दिया है उन्होंने. तो जो 15 और 16 कॉलम है महाराष्ट्र ने ऐड किया है. नाउ गवर्नमेंट ऑफ इंडिया इज एडिंग, सो वी आर अहेड. So this is very important slide. इसमें क्या दिया है, जस्ट द पेशेंट व्हाइल स्पीकिंग विद देम. इसमें क्या है कि अनमैरिड पेशेंट है, 18 साल से ऊपर है, तो आप एमटीपी कर सकते हैं. पर वो बाद में अगर उनके झगड़े हो गए तो उसमें एक एडिशनल आपने कंसेंट, इसमें फॉर्म सी इज वेरी मैंडेटरी. फॉर्म सी तो मैंडेटरी है, उसमें लेके आपको इसमें क्या बोलना है कि फॉर्म सी देना है हमको, और फॉर्म सी के बाद में एक अलग से उनका ये लीजिए, और उसमें क्या बोलना है आपने कि दिस प्रेगनेंसी टुक प्लेस during consensual sexual activity and I don't have any grudge or complaint against anybody here with and in future also. एक अंडरटेकिंग उससे लेना है, एडिशनल रख देना है, क्योंकि बाद में उनके झगड़े हो गए, उन्होंने रेप का केस डाल दिया, तो आपके पास पूरा हो रहा है कि हाँ मेरे पास आई थी, टर्मिनेट किया, 21 साल की थी, ये उसका अंडरटेकिंग है. ये फॉर्म सी है, फिनिश, यू आर फ्री. तो ये थोड़ा जज करिए. स्टेप 1 ओपीडी रजिस्ट्रेशन कर लीजिए. स्टेप 2 टेक कंसेंट फॉर्म सी में और एडिशनल. स्टेप 3 में क्या, कंप्लीट फॉर्म 1, और ई कब है 20 to 24 के बीच में फॉर्म ई नया आया हुआ है, वो ले लीजिए, डॉक्टर्स ओपिनियन फॉर्म. स्टेप 4 कंप्लीट द एमटीपी एक्चुअल प्रोसीजर. स्टेप 5 कंप्लीट पेपर वर्क, ऑपरेशन नोट्स. एंड स्टेप 6 एवरीथिंग इज पुट इन दैट एनवेलप, सील इट, कॉन्फिडेंशियल लिखो और हॉस्पिटल के मालिक के पास दो. इफ यू आर ओनर ऑफ द हॉस्पिटल, आपके पास रहो. दैट्स ऑल. और हर महीने की 5 तारीख को आपको ये रिपोर्ट आपको भेजना. ईपीसीपी और एमटीपी का डिफरेंस है, आप सबको मालूम है. एमटीपी कैन बी डन एट एनी सेंटर्स, मल्टीपल सेंटर्स. पीसीपी ऐसा नहीं, जहां आपका नाम है वही आप कर सकते हो, 2 ही सेंटर पे कर सकते हो इन 1 डिस्ट्रिक्ट. आजू बाजू में रहते हो आप बॉर्डर लाइन पे औरंगाबाद जालना के, तो आई कैन गो टू 2 सेंटर्स इन जालना, आई कैन गो टू 2 सेंटर्स इन औरंगाबाद. पर वहां टाइमिंग लिखना जरूरी है. एमटीपी में वैसा नहीं, कितने भी सेंटर में जा सकते हैं ऑल इंडिया लेवल पे. स्टेट चेंज हुआ तो स्टेट अप्रूव्ड अथॉरिटी को इन्फॉर्म करो सिर्फ. एमएमसी कैसा है, महाराष्ट्र मेडिकल काउंसिल वैसा, बाकी कुछ नहीं है. Okay, no regular inspection for MTP which is there in PCP NDT, no renewal for MTP which is there in PCP NDT. renewal fees भी नहीं है, place approved है, non bailable, cognizable, non compoundable तो दोनों है, and rigorous imprisonment of 2 to 7 years for MTP and PCP NDT के लिए 2 साल की है. So anticipate, proper document कीजिए, everything, follow protocols, nothing was missed, and आपका train staff रखिए, he should or she should help you and not irritate you. Training and drills regular, and if needed I am always there. I have photographed, save my number, and I don't charge for anything. It is free of cost since 18 years, forever also. This is women empowerment India, this is women of India, and these are salute to these health workers, and this is my humble request to you to kindly vote for me in incoming election 21 to 30th of March, West Zone, Vice President Foxy. Thank you very much. Thank you, Kanpur Obesity Society, again for giving me the chance.
Thank you, sir. We all will vote for you, and please also vote and
Thank you.
support for us also.
Yes,
You
yes.
have given wonderful tips to all of us. And now I request Dr. Seema Dwivedi, please request the chairpersons to give their expert opinion within a short time.
I request Dr. Kavita Gandhi to kindly give her expert comment. Hello.
Dr. Swati is there.
Dr. Swati, Dr. Gurpreet was also there. Gurpreet ma'am.
Hello.
Dr. Swati, may you give the expert comment about the...
मैम आवाज नहीं आ रही है.
आ रही है मैम, आपकी आ रही है आवाज मैम.
वैसे तो सर ने इतना अच्छा बोला, पर फिर भी अपने 2 लाइन की he has told everything.
हेलो.
डॉक्टर स्वाति, आपके व्यूज क्या हैं?
Ma'am, it was an excellent lecture. My audio is audible? I'm audible?
Yeah, ma'am. Yes, ma'am.
It was an excellent lecture. So many very useful cases have been advised. So I am very thankful to Dr. Ajay Mane sir.
Thank you.
And very nice and very informative, sir. Very day-to-day common cases, and we commit very as a practitioner still we are in very dilemma and what to do when such cases come to us. Very useful lecture, sir. Thank you, sir.
Thank you.
Thank you very much.
Other chairpersons, other comments or any questions? Dr. Vaishali, Dr. Gurpreet, Dr. Kavita.
अजय, अपने जो बैक होम मैसेजेस हैं अजय, दे आर वेरी
जी मैडम, जी मैडम.
तो ऐसे इनको ना इस पे डालिए सो दैट वी कैन लर्न. हमारे जो स्टूडेंट्स हैं पीजीज, उनको बैक होम मैसेजेस करके ऐसे बना के डालो. प्रिपेयर इट, यू राइट वेरी नाइसली. तो ऐसे थोड़ा जो नया चेंजेस है स्पेशली जी बना के डालिए. इट विल बी वेरी गुड फॉर देम. बहुत वंडरफुल.
यस मैडम, I'll send it.
वंडरफुली प्रेजेंटेड. बस इसका एक 3-4 पेज में जैसे वो एक एसओपी बनाते हैं हम लोग लिखने के लिए, तो दैट इज व्हाट आई वांट.
हाँ मैडम जी, 100%.
Dr. Kavita is there. Dr. Kavita Gandhi is there.
Very good.
Madam, Ajay Mane sir, it's a humble request. Sir is contesting for the post of VP Foxy West Zone for the elections from Aurangabad side. I request everyone to cast your precious vote in favor of sir.
Gurpreet is there.
Yes.
Gurpreet is there. Okay, welcome.
He is always helpful. I mean, any time you call him, he's always there to help you. So that is very true. Advice free of cost. You have any MLC, you go to a lawyer. Even before having the lawyer, they will demand money, in lakhs, and that is the worst part of it. You get into any litigation, nobody is there to help you. But the main important point from Mane sir is that he will be there. He will not bother whether tomorrow later on he'll have to face the heat, but then he'll be there for you to help. So that is a remarkable thing from side of Ajay Mane sir. So humble request to all the delegates to cast your precious vote in favor of sir.
वो तो है ही है. और बताइए. डॉक्टर अजय माने सर तो जीते हुए हैं ही हैं.
बेस्ट ऑफ लक.
बाकी हम लोग के लिए भी.
Thank you ma'am. Thank you Meera madam. Thank you Kanchan ma'am. Yeah, we'll proceed with the next program.
Few expert comment from other Dr. Meera Agnihotri ma'am.
It was excellent. मैंने अजय को बोल दिया है, ये एसओपी जैसे बनाते हैं कंचन, ऐसे एसओपी टाइप बना के ही विल प्रिपेयर इट, तो हम अपने पीजीज को सर्कुलेट कर देंगे. दैट विल बी बेटर दिस थिंग. ठीक है ना? ठीक है. ओके.
Thank you so much for a wonderful session. Now,
Sir, one question, sir. Ajamane, sir, one question. I have MTP certificate up to 20 weeks. Is it necessary to take MTP certificate up to 24 weeks?
Nine, madam. I have told you, just not necessary.
Not necessary. Okay, okay.
No.
Thank you.
Okay. Now, Dr. Seema Dwivedi for the next session.
Thank you, sir, so much for clearing all our doubts regarding the new rules of MTP. Proceeding ahead with the webinar on a very burning topic of genital tuberculosis, I would like to introduce our moderator for the panel discussion. Our moderator, as I've already introduced, our Secretary COGS, Dr. Kanchan Sharma. My humble request to all of you to support her as a candidate for the study of Female Breast Committee.
Thank you so much. The next.
As I've already introduced, she's a dynamic persona, awarded with many awards, and has held many prestigious posts earlier in COGS and now very active as Secretary COGS. Our next moderator is Dr. Usha Goenka, President, Kanpur Obs and Gynae Society, a benevolent, kind-hearted, magnanimous personality.
enough. बस हो गया, आगे पढ़ाई बात
बोल दीजिए थोड़ा सा।
बस हो गया, चलो भाई इतनी बात हो चुकी है।
दो लाइन है मैम। She has held many prestigious posts in COGS, trained in IVF and infertility, and is postgraduate in hospital management and has passed distant learning program in medical law and ethics. So we have many great personalities having great knowledge in law. It is our proud privilege. And now I hand over the proceedings to our moderators to introduce our panelists and go ahead with panel discussion.
Thank you, Seema. Thank you for kind words.
Thank you, Dr. Seema, for your kind words. And now there is a time for panel discussion. I introduce my panelist. Please show the CV of the panelist. Our first and most dynamic and most learned panelist is Dr. Kiran Pandey. She is a professor and head of department, Gynae department, GSVM Medical College. She is ICOG Governing Council member 2021-22. She is president of Kanpur Menopausal Society and chairperson IMA WDW, and she is ex-principal GMC Kannauj, and she was president of COGS, IMA, and she has delivered many lecture and orations. She has special interest in gynae oncology, infertility. She has many awards in her feather. She has 15 national and 10 state level and 10 district level awards. And most important is that she is contestant for medical education committee, and my all best wishes to ma'am, Dr. Kiran Pandey ma'am. Welcome. Dr. Kiran Pandey ma'am is there?
Ma'am has gone for emergency.
Okay.
There was an emergency call from the deans, therefore she has left.
Okay. So second chairperson.
Panelist.
Okay for her. Second chairperson. I welcome Dr. Shri Hare Lahane. He is MBBS MD and he is at present president of Lahane. He is a first laparoscopic surgeon of Marathwada University, practicing at Vittai Hospital, Beat, and performed more than 60,000 laparoscopic tubectomies, including various camps. Welcome you, sir. This is a bouquet for you. Third chairperson, panelist, Dr. Anuradha Shevale. I welcome you, ma'am. You are at present president of Aurangabad Society. You are consulting obstetrician and gynecologist, founder member of Maharashtra chapter of ISAR. You are a member of Aurangabad OBGY Society, at present the president. You have done laparoscopic training at FPC Mumbai in 1992, IVF and ICSI training from Bangalore, oocyte and embryo vitrification training, attended many national and international conferences as faculty. You are a very brilliant person, ma'am. You have your publications are clinical study to know etiological factor causing male and female infertility amongst 2002. Third party IVF gives high success rate study at Shivali Hospital. You are so brilliant. You have done so many courses, especially running so good fertility center. Welcome, Anuradha ma'am. You are there.
Thank you, madam.
There is a bouquet for you. Welcome.
Thank you.
Next panelist is Dr. Anil Kayande. He is the president of Jalna Society. He is very brilliant again. He has done MBBS from Dr. PD MMC Amravati in 2001. He is a DGO in GMC Miraj in 2005. Registered Bandra Bhaba Hospital for 6 months and consultant gynecologist at Deepak Hospital, Jalna. He is a consultant and director at Vivekanand Hospital, and at present he is president. Welcome, Dr. Anil. You are there? Dr. Anil, you are there? This is bouquet for you. I have seen him. The next panelist, Dr. Rachna Jaju, a young and eminent gynecologist. She is a secretary of Latur OBGY Society, practicing gynecologist for last 12 years. She is a director of Jaju Hospital since last 10 years and past secretary IMEW DW branch Latur. And she was faculty and a special interest in difficult obstetrics and USG. Welcome, Dr. Rachna. You are there?
Yes, ma'am. Thank you so much for those kind.
Welcome, welcome. This is a nice bouquet for you, virtual bouquet. Thank you. Thank you for joining. You are muted. Next is Dr. Vijay Shinde. He is secretary of Jalna OBGY Society and director of I Hospital Private Limited, Jalna, Maharashtra. He is a very brilliant fellow running this Jalna OBGY Society very efficiently. Welcome, sir, Dr. Vijay Shinde. You are welcome. You are there? This is bouquet for you. Yeah. Next chairperson, next panelist is Dr. Praveen Mundada. He is a secretary of Udgir Society. Dr. Praveen R. Mundada, he is a director, Komal Hospital, Udgir, Maharashtra. He is MD Grant Medical College, JJ Hospital, Mumbai, and practicing gynecologist at laparoscopic surgeon since 2007. His area of interest is high-risk pregnancy and fetal medicine and laparoscopy. Next, this is a bouquet for you, Dr. Praveen.
Thank you, madam. Thank you very much.
Dr. Usha, ma'am, please, will you introduce Dr. Priya Shinde? Dr. Usha Goenka, ma'am.
Yes.
Please introduce Dr. Priya Shinde.
Sure.
दिक्कत हो गई थी, माइक्रोफोन में ही बोल रहे हैं. गुड इवनिंग एवरीबॉडी. डॉक्टर प्रिया शिंदे, शी इज, आवाज आ रही है? यू आर गेटिंग माय वॉइस?
आ रही.
Dr. Priya Shinde is MBBS, DGO, GMC Nagpur. She is consultant obstetrician and gynecologist at Shinde Multi-Speciality Hospital, Bhadravati, Chandrapur, Secretary Chandrapur of Gynae Society, ex-lecturer Shavangi Medical College, Wardha, Foxy Executive Member of Food and Drugs and Medical Surgical Equipment Committee, special interest in infertility and colposcopy, member Bhadravati Shikshan Sanstha, Bhadravati, Chandrapur. She is founder of Sabdamatri Group, NGO. Great, Dr. Shinde, you're welcome.
Welcome.
Thank you, ma'am.
Bouquet for you. Welcome.
Thank you, ma'am, very much.
Most welcome.
The next. Is there any?
Who's the next?
हाँ बस अब सब हो गए तो will you start speaking something 2 words about the tuberculosis with infertility, then we will start sharing the slide.
Okay. Good evening, everybody. Genital tuberculosis is a very important subject and one of the most common cause of infertility. It causes infertility in 30% of females. But whosoever is suffering with genital tuberculosis, incidence of infertility is 70%. That is the incidence, and it's very common in our city. The country top most in tuberculosis in India and throughout the world. Now, Dr. Kanchan is actually a very important topic, and we'll have panel discussion on genital tuberculosis. Dr. Kanchan, you can start now.
Welcome, brilliant panelists. All have gathered. We'll just have a few words of discussion because as we have seen, the genital tuberculosis is very important. So I and my president, Dr. Usha Goenka, has decided to have a few words of introduction about this topic, that is genital tuberculosis and infertility. So welcome all. This is my regards and welcome to all the persons, all the doctors, all the brilliant persons who have joined today. Because as we have seen, the Charles Dickens says that there is a dreaded disease in which life and death are so strongly blended that death takes the glow and hue of the life, and the life, the gaunt and the grisly form of death. That we all agree. Starting with the case presentation, the first case is Mrs. X, aged 28 years, married life is 5 years. A case of primary infertility gives history of initial menorrhagia for 2 months and then secondary amenorrhea for last 6 months, not responding to withdrawal bleeding with even progesterone and estrogen. Now, how to proceed in this case? Starting with the first question, what are important relevant points in history which will give you clue to diagnosis? This is the first question. May I have this first question to Dr. Rachna Jaju?
Good evening, respected moderators and all the panelists. Now, looking at the history of the patient, she is giving a history of menorrhagia followed by amenorrhea, and she is married also. So no obvious cause is seen, and even after giving hormones, she is not having any withdrawal bleeding. So all these points are suggesting that she might be suffering from genital tuberculosis.
Very right, very right. Dr. Praveen, what else points you will see in the history?
Only in history. Regular menstrual history is sufficient. We have to go ahead with the whatever history we have obtained and confirm or make a differential diagnosis for her amenorrhea.
Yeah.
Yeah, in the investigation, if we are readily available ultrasound, then we can put a transvaginal probe and have a look at the endometrium. If it is an infected endometrium or having lesions of the tuberculosis, it will be giving the clear cut or quite a good idea regarding the cause of amenorrhea.
Yeah,
same time we can have a look for the other etiology of the amenorrhea, like have a look at the ovary, pouch of Douglas. If the lesion is active, there will be signs of the tuberculosis, genital tuberculosis.
Very rightly said.
Then comes the invasive investigation, like we have to obtain the
इन्वेस्टिगेशन के बारे में बाद में बात करेंगे.
Yeah, sure. Thank you.
पहले हिस्ट्री. वेरी राइटली सेड. एमिनोरिया कहीं पर भी है. First of all, because even after amenorrhea, we have to rule out the pregnancy. That is very important. Amenorrhea, if there is no pregnancy at all, urine test is negative, then we will proceed on doing all the investigation and have different ideas in our mind. May it be local damage of the endometrium, or may it be at the hormonal level in the ovaries. What you say, Dr. Anuradha Shivale?
Good evening, everybody. So thank you, madam, for including me in this panel.
Yes, ma'am. Yes, ma'am. I think you're.
Then still she is not responding to it. So that is also very important history, because that means that this is very severe. And also we can go for investigations for secondary amenorrhea. Like you can do hormonal profiles, and also the saline sonography can help in this case, where we can do the saline sonography and see whether she has any Asherman's or adhesions. So all these investigations we can add.
Yeah, very right. The most important coming on the after the DD, that we have to rule out the amenorrhea pregnancy, and then we have to do investigation regarding the local damage of the endometrium and of the hormonal profile. Very rightly said. You are very brilliant. You all are very brilliant panelists. Hats off to you. And history of vague lower abdominal discomfort is sometimes there. Many times these patients are asymptomatic. Many times they present initially, because in 70% of the cases we see that there is fallopian involvement. So it present by the features of infertility. There may be involvement of endometrium in 50% of the cases. In 50% of cases, when there is involvement of endometrium, in initial stage there is menorrhagia, and after that, when there is adhesions and shrinkage, there are Asherman syndrome, endometrial damage, then it may present as amenorrhea, as is in this case, and it is not responding to hormones. So in this these patients, adults and female, presenting with the ascitic pain and low-grade fever. Even many times there is a history, and there are histories many times found of recurrent pelvic inflammatory diseases. So clinical feature, 20% have history of tuberculosis in immediate family and past history of tuberculosis, and in 10 to 11% cases they are asymptomatic. The systemic features, that may be menstrual disturbances, abdominal swelling. In case it affects the cervix or vagina, there may be postcoital bleeding, vaginal discharge, and dyspareunia. That is very rare. In less than 5% of the cases, this affects the lower genital tract. When there is direct infection, only then this genital tract is affected. So I'm coming to another question. Genital tuberculosis is a secondary or primary disease. May I ask to Dr. Priya? Dr. Priya Shinde, have you logged in?
Yes, ma'am.
Genital tuberculosis is a primary or the secondary disease?
Mostly, ma'am, it's secondary. Like primary is more common when it involves the lung, and sometimes we get the secondary.
Yeah.
It can affect the genital area, but mostly we get the primary one. And in this
secondary.
Yeah, and most common is fallopian tube.
Yeah, very right, very right.
Rarest is vulva and vagina.
Very rightly said, Dr. Priya. In the fallopian tube affection is 90 to 100%, almost 90% of the cases, we see that there is a fallopian tube affection, and most common involvement is of the, this is a secondary type of infection. Most commonly it comes from the lung. Hematogenous spread is most common, which comes from the lung. After that, it in 90%, usually 90% cases, it affects the fallopian tube, endometrium in 50 to 60%, and ovaries in 20 to 30%, and cervix 5 to 15%, and vulva and vagina to less than 1%. Dr. Lahane, Dr. Shivhari Lahane, I think he is there.
Yeah, he is there.
Sir. What are the relevant clinical examination findings in case of genital tuberculosis? Dr. Lahane, sir.
I think somebody else.
Dr. Lahane?
I think he's not there.
Dr. Vijay Shinde is there? Dr. Anil Kayande is there? Dr. Anil, sir? Yeah?
Can I take this, madam?
Yeah, sure. Please. Yes, please proceed.
Dr. Priya?
Yeah, if it is affecting the reproductive tract, mostly we can get the lower abdominal pain. Pain may be vague, persistent, it is not associated with the menstrual cycle. Then there may be episodes of acute abdomen pain. And if it is severe, then we can have the complaint of dyspareunia, dysmenorrhea. Sometimes we get the menstrual complaints, mostly which I know is scanty menses or amenorrhea. But sometimes patient may have other complaints like menorrhagia, metrorrhagia also. And if she is trying to conceive, the patient may have infertility. It's difficult to conceive also.
Most common complaint.
Rightly said, Dr. Priya. Any other comment by Dr. Anuradha? Actually, these signs, they depends more than 50% of the cases. When you see, most important sign is normal. When you examine the patient, there are no features in many of the cases, but you suspect and investigate. You get only symptoms. That is of infertility, maybe amenorrhea, but on examinations, there are no finding at all many times. And the abdominal examination, as Dr. Priya has told rightly, Dr. Praveen, will you enumerate them again?
And the signs will be, I think, depend on the stage of the disease.
Yes.
The tuberculosis is already happened to the patient. As you told, patient may not have the symptoms, signs, but the disease is active in the patient. We will definitely get the signs. Signs in the form of cervical tenderness, or maybe dewy feel of the abdomen, and might be low grade fever, and all these things are there.
Actually, that depends which part of uterus is being affected. If it affects fallopian tube, in early stages, there is no features, no signs and symptoms. In case it affects the abdomen, endometrium, there may be tenderness, there may be doughy feeling in later stages. In late stage, it affects both the ovaries and cause abdominal mass. In that case, there may be abdominal masses. This is very late stage and you can feel them. There may be tenderness, very rightly, in case it affects the cervix and causes endometritis. There may be ascites in case it affects abdomen and there is ascites. There may be ulcer in vulva, vagina and cervix in the late stages. Very rightly said by Dr. Praveen and Dr. Priya. Thank you. Now, what are the relevant investigations advised? General Dr. Usha Goenka will be taking the next question. Dr.
Okay.
Usha.
Thank you, Kanchan. First, show me the question. What are the relevant investigations as devised, general as well as specific for diagnosis of genital tuberculosis? May I ask this question from Dr. Shivhari Lahane? Dr. Lahane, will you take up this question? I think he's not there. Dr. Anuradha? Dr. Anuradha Rajendra Shivhari, are you there?
Shivali.
Hello.
Hello.
Dr. Anuradha?
Yes, ma'am. Yeah.
Would you like to take up this question?
Yeah. In general, we can take some, general investigations. We can do general blood count, or even sometimes if we are suspecting tuberculosis, then we can even do TB gold test. And also there are some relevant tests like lymphocyte count and all those things which diagnoses tuberculosis. Also X-ray chest we can do to rule out pulmonary tuberculosis as a primary site. And specific investigations, there are few investigations we can do is hysteroscopy we can do along with DNA TB PCR testing. That also can give us some clue. Also, along with hysteroscopy, we can do diagnostic laparoscopy. Sometimes in diagnostic laparoscopy, there are we can diagnose tuberculosis. So that is one of the way to diagnose genital cocks in early stages. And also about the DNA PCR, many times we send DNA PCR testing, but it never comes positive. But still, the patient has low grade tuberculosis. So that also we have to think about. And even if clinical suspicion is also very important, we can, without any positive findings, we can give her anti-cox treatment. Yeah, other tests for endometrium are endometrial biopsy, then we can do the cultures. But the gold standard, I think, is DNA TB PCR.
Very right, you said. Any other you want to add, doctor? Hello?
Yes.
Very rightly said. Dr. Priya or Dr. Rachna, anyone? Dr. Praveen is there?
Yes, ma'am.
Dr. Priya.
The most important thing remains in the tissue-specific diagnosis. We have to come to the point and diagnose the disease. What we are dealing with the genital tuberculosis, either do hysteroscopy and get a biopsy from the endometrium. If you don't get anything in the endometrium, go for the laparoscopy, find out if there is any lesion in the POD or pelvis or anywhere in the abdomen. Once you are seeing some lesion, obtain a biopsy, subject it to histopath study, confirm the diagnosis, and most of the time, possibly you should be starting the treatment only after confirming the diagnosis, either by histopath study or DNA PCR study. Empirical diagnosis and empirical treatment should be given a second thought.
Very right. Dr. Priya, any comment about the lab investigation we want?
Lab investigations. Wait, I missed something there. We will start on the general examination like CBC, basic PSR, Tridot, then Montauk's test for the primary cause chest X-ray, sputum for AFB.
Yeah.
And for local, for the systemic examination, then sonography. And then for the confirmation, if it is still doubtful, then laparoscopy. And we can, with the laparoscopy, we can have this curettage, and then we can send it for TB PCR and histopath.
Hysteroscopy, yeah.
I will like to add one thing.
Yeah, Dr. Swati.
Sure. Yeah. Dr. Anuradha, बताइए.
Hello.
Please go ahead.
The sample collection is very important when we are doing this TB PCR. The sample should be collected premenstrual sample, because most of the bacteria, they are at the top of the endometrial gland when it develops in the secretory phase. So we have to do the sample collection for TB PCR in the late secretory phase. That is also very important point.
But I just want to add one point. Whenever you're taking in premenstrual phase, please get your beta HCG done or pregnancy test done, because these patients they're very hyper, that they are pregnant all the time. So we should prove that they are not pregnant before taking any premenstrual biopsy. So one of our patients, she created havoc that I was pregnant and doctor has done my MTP. So from that day, I always do a beta HCG and urine pregnancy test, then only I go for premenstrual biopsy.
Okay, madam. Yeah.
Okay. Yes. Any other points, Dr. Usha, ma'am?
Yes. See, quantiferon TB gold test is a very gold standard test because it needs at least 10 to 100 bacterial load for diagnosis. And the spot test is an oversensitive test. It diagnoses even the dead bacteria. It's not very diagnostic. We should go for quantiferon TB gold. Even a simple Montus test is quite informative with a specificity of at least 60 to 70%. Then we can go ahead and for diagnosis, even HSG, hysterosalpingogram, gives us a lot of information because every patient cannot afford a hysteroscopy or laparoscopy. And HSG is quite diagnostic.
But if we are suspecting
then we should not
tuberculosis,
do.
then we should it is a contraindicated.
Contraindicated. Yeah.
It will
It is
clear up the
contraindicated, but it has to
infection.
be done in every case. It is only contraindicated in papers. But in every case, we have to do hysterosalpingogram.
Whenever we are having the tuberculosis diagnosis in our mind,
then we will not do HSG. Yes.
So you are not doing it.
We are not doing HSG in case we have any
If we are
suspicion of
suspecting.
tuberculosis because this will start the tubercles.
Then
In case we are not having any doubt.
Excuse me, even then we cannot do hysteroscopy then? We are putting fluid in we are putting saline or RL in hysteroscopy.
In case we are having any doubt, then hysteroscopy and mainly
we are heading with the diagnostic purpose. Means we're trying to obtain the biopsy and we just try doing that.
Okay. Yes, right.
HSG is usually contraindicated in case you think about the genital tuberculosis. So HSG is contraindicated in by chance if you do, then there are so many features. What are the features if you do by chance, and that we have to discuss here.
Okay. Okay, done.
And even, madam, we can suspect in cases of thin endometrium. While doing a follicular study, if we are getting recurrent thin endometrium, which is not responding to the estrogen.
Yeah, right.
So those cases we have to suspect tuberculosis.
Right.
Thank you.
Thank you. Very nice. Will you advise a biopsy or sampling and or additional lysis during the lepro or histro? What advice and what is contraindicated? That Dr. Usha Goenka hai. Throw some light about the hysteroscopy or laparoscopy, when to advise or when not.
Yeah,
in
the
such
panelist.
patients.
Who is taking the question? Dr. Rachna Jaju? No. Should I
Ma'am,
tell?
if we are sure that the cases of genital tuberculosis, then we should start her with treatment and let the adhesion settle and then go for diagnostic hysterolaparoscopy. But if we are not sure about the diagnosis and we are doing it for diagnostic purpose, then we should go ahead and perform hysteroscopy and laparoscopy, because there will be findings in hysteroscopy, as said earlier, that there will be thin endometrium, then there will be atrophic cavity. In laparoscopy, we may find beaded appearance. We can take a biopsy sample and send it for histopath. So when it depends on what we are trying to do. If we are confirmed with the diagnosis, then we should not go and wait for adhesiolysis. But if we are not very sure, then we should go ahead with hysteroscopy and laparoscopy.
Very rightly said. 3 claps for Dr. Rachna for rightly saying all the things. You are very brilliant. Dr. Anuradha ma'am, please give your expert opinion too. Because here I see only Dr. Rachna, Dr. Anuradha and Dr. Praveen. Other panelists, are there any other panelists?
What are the findings of hysteroscopy, Dr. Rachna?
Dr. Anuradha, aap boliye.
Yeah. Actually, madam, I have one question in my mind, that it is always told to us that we have to diagnose tuberculosis first and then treat. because unless we have a diagnosis in our hand, we cannot give them anti-cox treatment. So that is under our this national program. But many times we don't get even TB PCR positive, but still we get some findings at the hysteroscopy or laparoscopy, and then we start with the anti-cox treatment. But giving it blindly, I don't know how far it is encouraged, and if the patient gets any adverse effect of those tablets or side effects, then maybe they will ask us question how you have started
No,
us
we
with the
can't give it.
anti-cox treatment.
In these medical legal times, you can't give without any proof.
There are a lot many discussions about this, that whether, because genital tuberculosis is such a disease in many cases, like only infertility is there, and there are changes which start taking inside the fallopian tube, and you don't have any definite proof in this. Many times this is said, there was a lot much of discussion between tuberculosis specialists and we, and all lot many meetings. They have discussed that even on suspicion, you just write because she is having an infertility problem, and by your clinical acumen, what are the positive features about the infertility tuberculosis which you suspect, you can start this treatment. And seeing even Mount-2 test in these cases is highly positive, and any past history of chest tuberculosis, fever, and in the relatives, you can start even the treatment, and after that you can have these diagnostic features also.
I think better it should be very well informed to the patient and the relative. It should be mentioned on the paper clearly that it has been started with the empirical diagnosis of tuberculosis. And we may stop the treatment or continue the treatment depending on the patient's clinical situation. So it should not be very randomly starting.
Always, very right, very intelligent version. Always we say that whenever start ATT, you should be well informed, well counseled, so that she has to complete her course, full course, without any miss in between. Otherwise, she will be resistant of the ATT. So आपको अच्छे से समझा देना है कि बेटा आई एम स्टार्टिंग दिस मेडिसिन बिकॉज ऑफ दिस किसी उसमें भ्रम में ना पड़ो, एंड इफ यू आर एक्सेप्टिंग यू विल बी वेरी रेगुलर, प्लीज गो विद इट and you may have a positive results. That is our strategy.
Madam, I have got one question, madam. I'm not a panelist, but I've got one question. I have seen
Doctor?
Hi, Gurpreet, madam.
Dr. Gurpreet, yeah.
Yes, madam. Because TB is notifiable, madam. If you are starting AKT, we have to notify the government. In frank cases, even with miliary tuberculosis, on laparoscopy, when do you actually see the tubercles? And when you take out the endometrium and send it for TB PCR, it comes out negative most of the time. And in such cases, when we start AKT to such patient are questioning us कि जब हुआ ही नहीं है, positive ही नहीं आया, then on what basis are you start? Because these are all hepatotoxic medicines that we are giving. All are hepatotoxic, and we need to get them checked every month for the liver function test and other tests. So if we give those 4 drugs, that is the intensive therapy for the first 2 months, it is too much for the patient. So in cases में patient को बताना भी बहुत difficult होता है, madam.
Actually, Dr. Gurpreet, very nice question. Very nice question. My husband is a chest specialist. He is a tuberculosis specialist, and we are notifying all the tuberculosis patient to. There is a proforma from the CMO office, and we are fulfilling and submitting every month to CMO office. So first of all, we take his advice too, and in these cases there is very much importance of the counseling. We counsel, and to the patient, look, we take the pictures of the laparoscopy in case you see the tubercles. We say that in 50 to 60% of the cases, these pathological lab investigation doesn't tend to be positive, but because of these features, you are a tubercular patient, and we have to start your medicine, and you have to be very regular. In case you have any features of jaundice or any like rifampicin toxicity or anything else, we have to stop or change your medicine, but without informing us, you will not stop your medicine. I do say to my patient, you miss even your lunch or dinner, but don't miss this medicine. Make a time and be very regular and particular. So by your counseling, patient follows it.
Well, most importantly, but before we start the medicine, we have to take a signature of the patient on her prescription that I am starting the medicine, knowing that the test is negative, still I am agreeing to take the medicine.
Okay.
And I know all the side effects. I have been informed of all the side effects.
Yes.
Then only start the medicine. We are doing for the advantage of the patient, but patient many times they come after आपने शुरू कैसे कर दिया when the diagnosis was not done. And there's so many people counseling them all the time. Patient
Yes,
is not
yes.
a single person. There's a whole society behind them.
I think in such situation we should obtain second opinion of the expert or our colleague on the paper that the whatever treatment or suspicion is done, it is for the tuberculosis and it has been correctly done and we have started the right treatment.
Right treatment.
Better one or another opinion will make a matter and make the side more sound.
Yes, very
My
true.
advantage is that I take the opinion of chest physician, my husband, and he just write. Then I say कि chest physician ने भी कहा है, tuberculosis specialist ने कहा है, और ये features हैं आपके इसके favor में, and then I am starting. Of course, consent is very important nowadays. Thank you so much for your Dr. Gurpreet also.
Thank you.
You're very active and very important suggestions you have given. Laparoscopic findings. When we are doing, anyone will enumerate laparoscopic finding?
Tubercles on the peritoneal surface,
Yeah.
inflamed or blue-colored uterus, salpingitis, oophorytis, or TO mass, tubal occlusion with hydrosalpinx, dye dripping instead of free flowing from the fimbrial opening on the promopertubation, free peritoneal fluid looking like blood, caseation in the pouch of Douglas, frozen pelvis. These are the few laparoscopic findings. And I'm not able to see.
Momental adhesions.
Yeah.
Period appearance symptoms.
Very rightly said. Anybody else want to give some other opinion?
Beaded appearance.
Beaded appearance. Dr. Rachna, like this, these are some features of on laparoscopy. Very rightly, very intelligently, Dr. Praveen. आपने सब कुछ बहुत अच्छे से बताया. Dr. Rachna, कुछ और ऐड करना चाहेंगे आप?
Ma'am, there will be extravasation of dye, I feel, and tiny tubercles will be seen. That is already elaborated by sir.
Elaborate. Tobacco pouch many times because of adhesions, because tuberculosis is such a disease in which there are a lot many adhesions and fibrosis at the fimbrial end. There are so many changes. Tobacco pouch. Meanwhile, while doing laparoscopy, you can push the dye from by the histoscope also, by the vaginal route.
Even if we don't find any classical lesions and there is plenty of free fluid in the pouch of Douglas or the abdomen, that fluid we can take and we can subject it to either that DNA PCR or even simply doing ADA test. And if it is the on higher side, it will be more like confirming the tuberculosis and it will help us to start the treatment.
Because of adhesions in between, there is a beaded appearance. There may be tobacco pouch because there are adhesions at the fimbrial end and collection of the dye there, retort shape, tobacco pouch appearance, hydrosalpinx, and there are multiple.
Madam, even suprahepatic adhesions, subdiaphragmatic space we inspect in cases of laparoscopy. even if we don't get any clue in the
Dr. Priya?
pelvis. Hello.
Yeah, are you there?
Yes,
Hello.
ma'am. Yes, ma'am.
Perihepatic
I
adhesion.
think perihepatic adhesions more
Yeah,
common in the
perihepatic adhesions.
chlamydial infection. They are seen in the tuberculosis as well, but more goes in favor of chlamydial.
Very right. Dr. Priya, will you enumerate them?
Ultrasonographic features, ma'am.
Yeah.
As you already discussed, we can get the thin endometrium, then free fluid in the cul-de-sac. If the tubes are involved, then we can have hydrosalpinx, bilateral or unilateral tubo-ovarian mass. Then some ascites may be there. And if there is a pyometra, we can have an enlarged uterus on sonography.
Very right. Very right. Thank you so much. Because ultrasound अब इतना advanced हो गया है कि on seeing ultrasound, you can see even many times there is a hydrosalpinx. There may be collection of the fluid inside the tubes. That can be very well appreciated on ultrasound. In late stages, when there are pelvic masses, you can see them. You can measure them. Thin endometrium is very well diagnosed in ultrasound. So in case there is pyometra, you can see, or any other. Dr. Usha Goenka, ma'am,
Yes.
will you take the question?
Yeah. The next question is, describe the pathogenesis, that is disease spread and involvement of the tube, fimbria, endometrium, etc. percentage wise and disease manifestation wise. Dr. Rachna, will you take the question, please?
Rajeshri Mahajan, madam, you have to mute yourself.
Hello?
Rajeshri Mahajan.
Dr. Rachna Raju, will you like to take up the question?
Yes, ma'am. There can be spread from the submucosal layer into the muscle, and it may result in fibrosis and adhesions, or then there might be an exudative spread which might result in pyosalpinx at the fimbrial end or a tubo-ovarian mass.
And
there may be caseation and necrosis resulting in ulcerations repeatedly and adhesion formations in the pelvis also.
Yeah, very rightly said. Dr. Usha Goenka, ma'am?
Yes. See, the spread can be from fallopian tubes downwards. If it is involving the fallopian tubes, it can be exudative or it can be inside, from the mucosa inside. If from the mucosa inside toward the medial side, then it will be, there will be hydrosalpinx, there will be coagular appearance on the ultrasound, and there will be osteal fibrosis. And if it's exudative type, then it will be plastic adhesion of the fimbria, and there can be ophoritis also. And ophoritis can be from the hematogenous spread, then it is from the center towards the exterior, or it's from the fimbrial end, it's from the surface towards the inside. And there can be caseous deposit on the ovary. And the most important finding is the tubes become rigid. The mobility of the tubes become restricted. Then it goes towards the endometrium. There's be endometrium hypoplasia. There can be interuterine adhesions. And in very rare cases, about in 1% cases, there can be involvement of cervix. There can be polypoidal growth or ulceration, or on vulva, there can be small polyps. But this is very, very rare. Vulval tuberculosis and cervical tuberculosis, they're very rare findings that can be there. And then can be ascites in the, because it doesn't leave even the intra-abdominal organs. There can be ascitic fluid, there can be fimbrial ventral pouch of Douglas, and it can involve the intestines also. Many times on doing laparoscopy, we get even tubercles on the omentum and peritoneal surfaces of the intestine. That is the thing. And that's why during the biopsy, we take day 1 or premenstrual biopsy, because this is a submucosal layer of the endometrium which keeps shedding and keeps reinfecting. It gets shed during the menstrual cycle and reinfects. That's why we can take menstrual blood also for micro-PCR. And that's very diagnostic also. In many cases, I am doing in my patients, I do take swabs of menstrual blood and send it for micro-PCR or AFB or many times if the collection is quite some, then I can send it for tubercular culture also. It's a non-invasive test, and patient agrees to it very nicely. And if the tuberculosis, this mucosa is shedding, it's getting infected during menstrual cycle, and if it grows inside, then in fact affects the myometrium, then it causes fibrosis of the uterine wall, and it leads to amenorrhea. Okay.
Yes, sir.
Okay.
So, in rare
What's the
cases,
next question?
in last stage is the frozen pelvis. So now, role of hysterosalpingography and the finding. Normally, as we say that hysterosalpingography is not being suggested. So I asked to Dr. Rachna Jaju, in case you do the hysterosalpingography by chance in these patients, what are your important findings on hysterosalpingography?
Ma'am, on doing hysterosalpingography, there will be extravasation of dye that will be seen. Then there will be, as Madam had said earlier, the tubes will become rigid. Then there will be hydrosalping appearance of the tube, a tobacco pouch appearance, as already been stated.
Yeah. Very rightly, very rightly. Any other, Dr. Praveen? Dr. Praveen is there?
Yeah, I am there.
Yeah, is there.
Yeah. Please tell any other findings.
The findings that are listed here, like leopard skin appearance, rosette appearance, mouth eaten appearance, sperm head appearance, beaded, and distal tubal obstruction, coiling, calcified shadows, bilateral corneal block, irregular honeycomb appearance of the uterine cavity.
Very
Most
rightly.
importantly, excuse me, most importantly, when we do HSG, when there is fibrosis of the external os, and if we are able to manipulate through the cervical canal, there can be fibrosis of the internal os also. And then when we pass the dye, it's very difficult. It goes under pressure. If it is going under pressure, we should be very sure that there's some adhesions inside the uterine cavity, or uterine cavity has become T-shaped, or the lumina of the uterine cavity is decreased. Then don't keep pushing the dye. Number one. Secondly, there can be beaded appearance, there can be tobacco pouch appearance, there can be ledge pipe rigidity, or there can be absolutely blocked tubes from corneal end. There will be bilateral blockage, there can be unilateral blockage, there can be sperm head appearance, there will be gold club appearance. There's so many things which can be seen in HSG. But one thing I would like to advise you, whenever we are doing your HSG yourself, what I do, when I put the dye, I aspirate the dye. And I aspirate the liquid, and then I send it for micro-PCR or AFB. If at all we get some findings, we are very sure of HSG. And I always do HSG of my patient myself. That it is quite diagnostic for us. And we say it is contraindicated, but you see, in most of the infertility patients, how to diagnose for a tubal factor infertility. Every patient cannot afford laparoscopy. There are so many patients of mine. First of all, they can't afford. Secondly, it is an invasive test. Most of the family denies. Doctor, abhi operation nahi karayenge, जल्दी operation nahi कराने वाले हैं. Hysteroscopy फिर करा लेते हैं, laparoscopy आते हैं, patient नहीं कराते. Tubal factor infertility के लिए we have to go for HSG with due precautions.
Yeah, very rightly said. बहुत ही अच्छे से सबने हमारे सारे.
Madam, is HSG enough to diagnose genital tuberculosis and the
no. But tubal factor infertility is a
we
very
cannot stop on
important.
just doing a HSG. We have to
not
go
at
ahead.
all. I'm just saying it's a very important investigation to diagnose tubal factor infertility.
Yeah, that is
actually,
correct.
Actually, very rightly said.
Tuberculosis. I mean tuberculosis
It's the first important test in the infertility that we must do.
that we were doing since long actually. Because the findings, they depend on the part which is being affected, because as we see that tuberculosis is genital tuberculosis is a secondary disease, and there is a hematogenous spread. In most of the cases, hematogenous spread primarily from lung, or there is a direct spread from the abdominal organ. That is a second cause. So in these cases, mucosal lining is first of all being affected. So first of all, as there is hyperemia, then there is scarring and adhesions. Because of these affections, there is in between beaded appearance, where there is scarring and adhesions, and in case these scarring, collection of the fluid that happens on the edge, that is on the fimbrial end, then there is retort shape because of the collection, retort shape, tobacco pouch, and beaded mouth eaten. These all appearances which we mention is because of its different pathology. And this is not a diagnostic. We have to take other features also, as we were since long discussing.
Madam, what is
Dr. Gurpreet?
Yes. Hypoxia, which is being advocated these days. Have you tried that, ma'am? Contrast with the contrast, and you need not go for X-ray exposure. On ultrasound itself, when we inject the dye, and you can do it.
Yes. We have discussed a lot.
Is that a better modality than hysterectomy these days?
Actually, we have discussed a lot many times about that, and many persons, even there were many trials, many papers on it. They are injecting this dye, radio opaque dye, ultrasound opaque dye, and doing that. But I think my personal experience, because I'm doing ultrasound, I'm doing this all, but I find better result on hysterosalpingography. What is your experience, Dr. Gurpreet?
No, madam, I haven't tried this.
Because I have done, but even then I prefer to do this HSG, because better record, better visibility, and everything is better. I prefer.
Madam, can I add?
Yeah, sure,
Dr.
Dr.
Anuradha, ma'am, please.
Yeah,
Thank you.
for that we need high-end machines, and that is really expensive thing. And also we have to add color Doppler to it, but still we can know the patency of the tube, but we cannot know whether the tube is deceased. Yeah, deceased, or what is the pattern of the tube. Only patency we can know. And saline hysterography is very good tool, what I feel. Right in the first visit also, when we are doing transvaginal sonography, we can add saline hysterography to it.
Right.
So that we can diagnose intrauterine pathologies.
Right, very right. Because actually you see the patency whenever on the color Doppler of my machine, I see the spillage. But in case HSG, there is a lining, and you see that here is the obstruction, this is the lead pipe, this is the beaded appearance. That cannot be appreciated well in ultrasound and this dye.
But I think the question still remains. The thing is that when we are having the strong suspicion of the tuberculosis,
we are not doing.
Are we justified doing
SSG?
No.
That was I think whenever we are primarily doing HSG for simply infertility, that's okay. But keeping in mind we are going to diagnose the tuberculosis and doing HSG, I don't think it is justifiable.
Right.
So better thing you do a transvaginal sonography. Have a look at the endometrium, tubes, and pouch of Douglas, and then you can, if suspicious, then you can go with the hysteroscopy or laparoscopy.
Yes, right.
Right. Very right.
Thank you.
Rightly said.
May I add one thing?
Yes,
May I add?
Yes,
what I do, see, quinolones are anti-tuberculin. What I do in my patients, if I have suspicion, I'm not saying I'm very correct, but I'm just giving my opinion. I give quinolones to these patients for about a week,
Not
and then I do HSG myself. And if there's a lot of pressure, then you stop doing HSG. Otherwise, do the HSG. But
not
my
advised.
patient put laparoscopy in every case. It's very difficult.
Actually, I have even asked to this TV specialist persons, because if you start these quinolones and because these have a partial effect of ATTs, so the patient get a resistant, has a few of the so don't start complete treatment.
नहीं, I'm giving only for a week. Patient can patient तो कितनी बार quinolone खा लेते हैं ऐसी, but they take for infections, for UTIs. They take.
आप वो दे के आप in case you are suspecting tuberculosis, genital tuberculosis, तो आप quinolones या इस टाइप की ATT मेडिसिन टाइप देकर अगर आप HSG करेंगे तो that is not
जानकर मत कीजिए मैडम, अनजाने हो जाता है तो कोई बात नहीं।
डॉक्टर नहीं, हम तो जिसका HSG करते हैं एंटीबायोटिक कवरेज में अम्ब्रेला में
वो एक that is
you never know कि क्या निकलेगा, you never know, you don't have a suspicion, but more than infertility patients they are tuberculous.
नहीं वो तो ठीक है, वो तो एंटीबायोटिक कवरेज में करना चाहिए, बट अगर आपको जरा भी सस्पिशन है कि
30% infertile patients को tuberculosis होती है, we are saying the statement that 30% of infertile patients have tuberculosis.
Yes, madam.
Means हमको किसी HSG फिर तो हम लोग करनी ही नहीं चाहिए किसी का।
नहीं, in case you are suspecting tuberculosis.
I'm not saying I'm right. I'm just asking a question from the panel.
Yeah.
I'm just asking every panelist what to do then.
Madam, all these studies must be foreign studies, no? So in India, tuberculosis is very common, and I think patients are usually below poverty line. They have more chances of having this genital cocks. So I don't think we have any other investigations where we can diagnose and we can know even the tubal status, which is cheaper and so diagnostic of tubal diseases.
Every patient cannot afford 20 from TB PCR. TB
Yes,
gold भी हर
yes.
patient नहीं करा पाता।
मैडम गवर्नमेंट में फ्री होता है आजकल TB PCR।
आजकल तो रहा
वहाँ लोग जाना नहीं चाहते डॉक्टर साहब।
नहीं, सैंपल हम भेज सकते हैं ना, हम
तो भेजते हैं,
हम भेज सकते हैं, खुद भेज सकते हैं अपने लैब से, कोई चार्ज नहीं।
अच्छा, हम लोग अपने यहाँ से भेज सकते हैं, ये
भेज सकते हैं, यहाँ डॉक्टर के हम लोग के पास से जाता है, क्योंकि और बिल्कुल फ्री ऑफ कॉस्ट होता है, गवर्नमेंट ने फैसिलिटी दी हुई है, हमारे यहाँ से जाता है सैंपल। डॉक्टर साहब जो पुअर पेशेंट हैं, हमारे हस्बैंड ही एडवाइस, और यहाँ से कलेक्शन के लिए बंदा आता है CMO ऑफिस से।
This is a good information for me. I didn't know.
Thank you, madam.
Thank you, Dr. Praveen, for this good information. Thank you so much.
Even I was not knowing, madam.
Yeah, they are coming and sample is being collected from my side even.
Start the treatment, Dr. Kanchan.
आप ट्रीटमेंट आप बोलेंगे मैडम? Ask the question.
Dr. Praveen, they are very, very aware, and all of them are very well informed. Now we'll go for the treatment. We have diagnosed tuberculosis, patient has got pelvic tuberculosis, then how we are going to treat the patient. May I ask this question from Anuradha?
Yeah, usually it is 4-drug therapy for initial 2 months, and then maintenance therapy for another 4 months. Total 6 months therapy we have to give for the cases of extrapulmonary cocks.
And also, Dr. Praveen, what is the combination of the drugs you like to give?
Yeah, when 4 drugs means INH, rifampicin, pyrazinamide, and ethambutol, or we can give streptomycin. But usually patients, they are reluctant to take streptomycin because of they don't want prick. Then we can give these oral drugs and maintenance with INH and rifampicin.
Very right. ठीक है.
And what is the duration of treatment for pelvic tuberculosis?
It is 6 months, madam.
ठीक है.
And we will, if the patient get pregnant by chance, will we be continuing the medicine or will we stop the treatment?
Yeah, we will continue. Yeah.
Which medicine will continue? Which we will stop?
Pyrazinamide will stop.
Okay.
Patient conceives in the maintenance phase, it's a good thing. Then we can just
by chance, if by chance
continue, continue with the
continue the line of treatment.
Because accurate like 4 RHA-FD 4 drugs agar hain to use.
And doctor, what precautions will ask the patient, or what symptoms if she develops she should inform us? Can you tell us, Dr. Praveen?
we should be keeping in the mind the potential toxicity with the liver. All these are potentially toxic drug. So we should ask patient whenever she feels loss of appetite, nausea, vomiting, giddiness, or yellowish discoloration of her nail beds or sclera. Usually, once we start the AKT, and if patient is tuberculous, she will tolerate these drugs very well, and she will start putting on the weight.
Yes, very right.
But instead of that, if she's again complaining the same things like nausea, vomiting, abdominal disturbance, then she should be called with a time of a week or two for the LFT. We should do the enzymes, and whenever we find the raised enzymes, hold on it. Keep patient on the non-hepatotoxic combination. Repeat the enzymes after a couple of weeks. If the enzymes comes all right, we can restart the full course of the treatment.
I want to add one thing here, sir. Whenever we are giving the 4-drug therapy, we need to add pyridoxine because isoniazid is highly causes peripheral neuropathy.
Folic acid and pyridoxine.
And for ophthalmic complication, we should be make the patient very aware. In ethambutol, there are a lot of ophthalmic complications.
Yeah.
We should make the patient ask, so vision में कोई दिक्कत हो आप जरूर बताएं तुरंत हम.
And each month, when we even before initiating the AKT, we should get liver function test done and follow her up after every month. Like we should get her LFT done because all are highly cytotoxic drugs. So many a times patients don't tolerate it and they have this renal hepatic issue.
Very true.
That is something which I have seen.
Yeah, very right.
Madam, regarding dosages, it is also important that weight of the patient, because most of the Indian women, they are less than 50 kg weight, and at that cases we have to use the dosage we have to adjust according to the weight of the patient.
Yeah.
Most of the patients with the genital tuberculosis, they are on lower side, like 30 kg, 35 kg.
Yes.
50 kg.
Yes.
Then we have to tailor the dose according to the weight-based dose adjustment.
One thing more, we should always give some supportive therapy to these patients, like multivites or protein supplements. But generally, these patients are undernutrited.
Oral support remains the most important point once patient is diagnosed with the tuberculosis. They are afraid of the social stigma. So we have to just keep the confidentiality of the diagnosis with us and the patient.
Yes, that's very important.
Moral boosting that it will be cured 100% if you complete the course.
Very right. These are बहुत ही अच्छे से patient को समझाना.
और एक बहुत important question हर patient पूछती है, डॉक्टर हमारे husband को tuberculosis नहीं है, हम contact करेंगे तो. We should make them. Yes. We should assure them that it's not sexually transmitted disease.
अगर active है तो
बहुत important नहीं, active tuberculosis is a different thing. They talk about genital tuberculosis.
तो आपको
It's a very common question by every patient and their family members.
15 दिन abstinence रखने बोलिए मैडम. 15 दिन के बाद
बोलिए. 15 दिन एक महीना.
15 दिन तो उससे बोल देंगे, लेकिन इनके उनकी जितनी मदर इन लॉ इंडिया में तो पेशेंट बाद में आती, मदर इन लॉ पहले आती.
मैं के भेज दो नहीं तो थोड़े दिन
ठीक है. तो अगर हमारे यही ट्यूबरकुलोसिस रेजिस्टेंट होती है या कुछ और होती है, then we have to take advice from our tuberculosis specialist doctors. Very rightly said, Dr. Anuradha, because you are infertility specialist too. So may I ask a questions to you, how to manage infertility in these patients? Dr. Anuradha?
Yes. If the patient has minimum tubal damage, then with anticox treatment, usually the tubes, they start functioning normally. But if she has extensive tubal disease, then we have to go for the some other modalities like IVF or ICSI. Even if the tubes are patent, but then also sometimes we have to go for the advanced treatment like IVF and ICSI. And other thing which is very important is once the tubes are damaged, then there is equal chance that endometrium is also affected. So in these cases, endometrial studies are very important. So we can prime the endometrium with estrogen for 15 days, and we do the endometrial blood flow studies before we advise them for the even for embryo transfers. So and one more question I have is that if the patient has received anti-cox treatment, maybe some 2 years back or 3 years back, so before doing IVF, if the endometrium is thin, can we repeat the course of anti-cox treatment and then go for IVF? I think that will be better if the patient is not responding, endometrium is not responding to the estrogen.
No. Actually, once you complete the course and this reactivation is not there, then you can adopt, because the endometrium is thin in many cases because of a dense adhesions and stricture. In those cases, we can adopt PRP plasma and other estrogen, etc. We are giving PRP plasma or other thing which we have be using. In my practice, we are using in IVF patient. Many patients, they were not responding, have a atrophic endometrium. They very well respond on PRP plasma. I have very much experience on PRP plasma. We have a prepared PRP tube, and we take 8 ml of the patient's blood in that, centrifuge at 3000 RPM for 10 minutes, and upper 1/3 portion we throw, lower we instill in the endometrial cavity 48 hours apart twice. There is a very good growth in these cases. It has been seen. Repeating in, there is no reactivation of the tuberculosis. Repeating is, I think, not advised in these cases.
Madam, one more question here. Once you give the therapy,
Dr. Gurpreet.
Yes, madam. Once you give the therapy, how do we know that the patient is completely cured now? There is no residual thing, because many of the patients are defaulters. They don't tolerate the medicine and they leave the treatment midway. And those patients, they come back to you again. Then how to we
This
judge?
is very, because I have asked even to my husband many times these questions. This is very important that आपको पेशेंट से ये उगलवाना है कि आपने बीच में मिस किया है कि नहीं, because उनको जैसे भी समझा के, because if you have missed even a single tablet, just tell her that then you will have to repeat whole of the course and you have many of complications. If the patient has completed whole of the course very properly, honestly, and telling to you, then of course after 6 months there is no residual disease as such. In the normal cases that I have asked to even a tuberculosis specialist. In case the patient is defaulter, then of course there is reactivation, and we may have to start with not those drugs but the higher other drugs and the combination, and by the consent of our tuberculosis colleagues.
Because these days, madam, we are having multiple drug-resistant tuberculosis, not even that, extremely drug-resistant tuberculosis. So when patients are defaulters, and many times they do default, they don't take the treatment.
Very right.
They come back to you for infertility management, and that's rightly as said by Dr. Anuradha madam. How to, in those cases, again, should we give the therapy, and how to manage those cases? It's a bit tricky, but
they are tricky because in these cases, resistant cases or defaulters, my husband starts to some higher medicines, because I refer these type of cases for treatment to him because she is a defaulter. Please start higher medicines for resistant type of tuberculosis or defaulters, and when they complete their course, then again to me. And
Actually, how can we know that the patient is totally cured? What is the right step to take to see whether the patient is fully cured or not? Even if the patient is taking full course, not be cured.
Clinical assessment depends.
Once the patient completes the course, he or she, without any missing of the medicine, he or she is totally cured by this medicine. That is for sure.
In spite of completing the full course of AKT, reactivation should be remain at the back of our mind. There are cases of spontaneous reactivation. I myself have witnessed a case, a young girl, which first time presented to me with the pot spine. After a gap of 3 years, she comes to me with the sauce abscess. She got married. After 3-4 years, she comes with the right side ectopic pregnancy. Again, with some gaps, she comes with the left side ectopic. So whether it was the active disease which was ongoing, whether it is a recurrence, whether reactivation, the question remains unanswered in such situations.
Yeah.
What I tell about one of my patients, she was tubercular patient. She conceived after treatment. She delivered 2 babies. Yesterday only she came to me with Pott's spine.
Yeah.
Madam,
She delivered 2 babies. After that, she has come with Pott's spine.
Yeah, there is one test to diagnose rifampicin resistance, like what you were talking about, the free testing by Government of India.
Yeah.
So that is the, I think, TB NAT test or something it is called as, and there they not just diagnose the this tuberculosis, but they diagnose whether this tuberculosis is resistant to rifampicin. So that is also one of the things we can do if there is recurrence.
Good. Yeah. Thank you, Dr. Anuradha.
Very
Thanks
right.
for the information.
Thank you, our brilliant panelist. As you said very rightly that in these cases we do IVF with the thin endometrium is always a headache for all of us, and there are so many new treatment which have come for it, PRP plasma and many other things, and other Dr. Usha Goenka, in short, very short because the time is too much, the extragenital tuberculosis, one word about that. It's a rare form of
ulcer.
Rare form is vulval ulcers, vulval polyps. I've already told there can be vaginal ulcerations, vaginal polyps, or cervical polyps and cervical ulcerations, which are very rare. This is only less than 1% in genital tuberculosis.
Very rare. In case कहीं पे अगर किसी ने infected person ने spit कर दिया है और कोई बच्चा बैठ गया है, कोई female, कोई lady बैठ गई है, कोई बच्चा बैठ गया है, many times that happens. So that is a reverse direct spread, very rare. Or some penile tuberculosis है, तो that may infect directly. It's rare or very rare. ठीक है, तो वेरी ब्रिलियंट, वेरी इंटेलिजेंट पैनलिस्ट और बहुत ही अच्छा डिस्कशन, बड़ा अच्छा लगा. थैंक यू सो मच डॉक्टर प्रवीण, डॉक्टर अनुराधा, डॉक्टर प्रिया, डॉक्टर रचना एंड ऑल द ब्रिलियंट पैनलिस्ट. कुछ लोग शायद लॉग इन नहीं कर पाए, हमने मिस करा. डॉक्टर प्रवीण आपने, डॉक्टर अनुराधा सबने बहुत अच्छे से अपने विचार रखे. थैंक यू सो मच, सच ए लर्नेड पैनलिस्ट. So genital tuberculosis is in summary underdiagnosed. Strong suspicion is the key to diagnosis. Prompt treatment of primary tuberculosis decreases the incidence. Routine blood tests are these which we have discussed. Infertility with poor pregnancy rate is seen in this genital tuberculosis. Thank you so much. Again, with folded hand, I'll request you. So please vote and support me for the chairperson study of female breast committee. Thank you so much. This was a nice interaction for all of you. Dr. Usha Goenka, any comments from your side?
Thank you, everybody. Thanks, Dr. Anuradha, Dr. Praveen, Dr. Rachna, Dr. Priya, Dr. Gurpreet, Dr. Swati, Dr. Kavita, Dr. Vaishali, for sparing your precious time and be with us. And you people have given us many new informations. Thank you so much.
All the very best, Kanchan, madam.
Thank you, Dr. Gurpreet. You are a very good friend. All Dr. Kavita is there. Dr. Kavita, ma'am, you are there.
Yes, she's there. Yeah.
अच्छा, आपके कुछ about your, कुछ आपके विचार about this?
Yeah, it was a very nice panel discussion. Basic सब कुछ cover किया गया है, and even Dr. Mane's tips were very nice. A very informative webinar.
Very nice comments.
Dr. Muted.
Dr. Vaishali, your comments, please.
Kanchan, there's one question for you in the chat box.
Dr. Vaishali is muted. Yeah.
Kanchan, there's one question for you regarding PRP in chat box.
Yeah.
That is the root of PRP. This is a question from one person. Please answer.
क्या है question?
PRP के लिए है देखा. What is the root of PRP?
Actually, PRP, what my experience is, अब तो इसमें ये है कि they are giving sub endometrial also by the long needle, but that is a bit difficult. By the histoscopy guidance, they are giving in the on the fundal region, anterior and posterior, but that required a lot much of the PRP and a lot much of the blood of the patient. But according to my experience, I take only their PRP tube which are prepared. I take 8 ml of the patient's blood and on 3000 RPM 10 minutes के लिए उसको चलाते हैं. After that there is a separation. एक yellow layer ऊपर आ जाती, 3 layers में separation हो जाता है. In yellow layer upper 2/3 फेंक देते हैं, lower one about 0.6 ml, 0.5 to 0.6 ml I take and fill in IUI cannula and instill in the uterine cavity. And patient lie for 10 minutes and I get very good response. And after 48 hours, we may repeat. And many of my patients who are having thin endometrium, they responded and they got pregnant even by this treatment.
Good, great.
So that is my experience. Dr. Vaishali, you were telling something?
Yes. Ma'am, it's very informative and excellent talk by all the panelists. It will definitely useful in our day-to-day practice. And thank you for giving me the opportunity as a chairperson. Thank you very much, ma'am.
Thank you, Dr. Vaishali. You are really, Dr. Swati want to say something. Dr. Swati, ma'am.
It's very good and informative.
Please unmute yourself, Swati ji.
कर लिया.
Volume.
Yes. Hello.
Yeah, Dr. Swati.
Ma'am, it was very informative and it was a very good and day-to-day routine practice में जो भी अपने को difficulties आते हैं, very nicely elaborated and very informative, especially regarding tuberculosis. Very thankful to all of you, ma'am.
Thank you. बहुत अच्छा लगा आपसे interact करके. Dr. Anil Kayande is login. Dr. Anil, are you there? Dr. Anil. I think Dr. Lakshmi ma'am, आप अभी हैं? Dr. Lakshmi ma'am? I think Dr. Ajay Mane, सबका login है, दिख रहा है? I think yes, Dr. Ajay Mane, sir.
Yes, ma'am. I was listening to all the panelists and you as a moderator. It was very nice discussion. And you have touched all the aspect of tuberculosis treatment. As said correctly by Praveen sir, it is mandatory for us to mention all the possibilities on the paper and then you can go empirically. It is not necessary to have a proof of positive reports with you. Empirically, you can treat tuberculosis because it is very common in India. So you can do that, but mention it on paper that empirically we are giving and patient is ready to take that treatment. So that was my point basically. Praveen sir said it correctly. So panel was very nice. Thank you very much, ma'am.
Okay, thank you so much.
And best luck to you.
Expert opinions. Thank you, sir. Dr. Ajay Mane, sir. Now the time is for the Thanksgiving. At the outset, my sincere thanks to our wonderful chief guests, Dr. Mandakini Meg ma'am, Dr. Meera Agnihotri ma'am, who have spared their valuable time to bless us and log in. My sincere thanks to our guest of honor, Dr. Pardesi sir, Dr. Lakshmi Shrikhande ma'am, who has given their precious time Dr. Ajay Mane sir, my sincere thanks and special wishes to you that you are very generous, very cooperative person. You have logged in and spoken in a very short notice and accepted our invitation. Thank you so much. Thank you, our wonderful chairpersons. Very nice, very brilliant, very good to interact all of you. And you have accepted our invitation in a very short notice. Thank you so much. My President, Dr. Usha Goenka, and co-moderator, Dr. Seema Dwivedi, thank you very much for the wonderful, wonderful panel. Dr. Praveen, you have answered very nicely. Dr. Vaishali, Dr. Kavita Gandhi, wonderful person. Dr. Swati Patil, thank you for chairing. Dr. Rachna Jaju, excellent answer. Dr. Anuradha, you are a wonderful person. आपने infertility के इतने अच्छे tips हमको दिए. Thank you so much. Thank you so much. Dr. Priya is not there. I think Dr. Priya.
माने सर के बारे में एक चीज बोलना चाहूंगा. माने सर मी तुमचा ज्युनियर आहे, MGM चा छोटा बंधू आहे. सर म्हणून लाजू नका आम्हाला.
अरे नाही, great. आनंद होतो. छान. You are at good position.
Sir, having the lot of knowledge of the subject, but one more thing I want to share regarding him. उनके पास jokes का भी बहुत भंडार है बड़ा. कभी टाइम मिला तो उनके साथ वक्त गुजारेगा. बहुत अच्छे जोक करते हैं.
Thank you, Praveen.
Mane is
all-rounder. Mane.
All the best to Kanchan Madam, Mane sir, and thank you all the eminent faculties for involving us in this discussion.
Thank you, Dr. Praveen. 3 cheers for all the chairperson, panelists, and speakers, and the guest of honor, especially Dr. Lakshmi, is still there.
I would like to thank you and Usha madam for giving us this opportunity to be here on this platform, and wishing all the best to you, Mane sir and Kiran madam. And as usual, Mane sir's talk was excellent, and you have guided us very well in this panel discussion. Thank you so much.
Thank you, Dr. Rachna.
Thank you, Rachna.
Very nice. And Dr. Gurpreet, your questions and interactions were quite intelligent. Thank you for that. And last but not least, very sincere thank to our academic partner, Shield Connects. All have very patiently and in a very short duration cooperated very well to us, Dr. Saurabh.
Thank you so much,
Raj, and all the team of Shield Connect. You are very cooperative, and thank you so much for helping us.
Thank you very much, madam. On behalf of Shield Health, lastly, I want to convey my sincere gratitude to all the faculties and eminent panelists, and also the attendees who had attended this informative session. And in future also, we will be very happy to conduct this kind of academic initiatives in our platform Shield Connect. Thank you very much.
Thank you. YouTube पे है क्या ये? हम लोग को recording मिल जाएगी?
Yes, madam, it will be there.
ठीक है, recording सबकी मिलेगी. हम लोग screenshot लेके भी.
Sure. Thank you very much,
madam. So much. Thank you. Good night.
Thank you, madam. Thank you very much. Thank you, Usha madam. Thank you, Kanchan ma'am.
Thank you.
Thank you.
All the best.
Thank you,
madam.
Thank you, madam. Thank you.
Thank you so much.
Okay, one thing I want to say, Dr. Kanchan.
जी.
या अगले बार सर को आप एक्सपर्ट कमेंट्स के लिए रखिए.
बिल्कुल.
टीबी का अगर कहीं रहा वेबिनार.
मैं बिल्कुल. अपने हस्बैंड डॉक्टर श्याम सुंदर हैं, and he is a batchmate of Dr. Usha Goenka. She is our president. So he is 5 years senior to me. And हम उनको बुलाएंगे बिल्कुल.
हाँ बिल्कुल. नए आइडियाज, नए ड्रग्स थोड़ा सा अपडेट हो जाते हैं.
बिल्कुल ठीक है.
चलो, ऑल द बेस्ट टू यू.
चलो बाय. ऑल द बेस्ट. गुड नाइट. थैंक यू वेरी मच.
गुड नाइट. Thank you.
Thank you, ma'am.
Okay. Thank you, Dr. Bye bye.